Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Distinguished colleagues, dear friends, let me welcome all of you, all those who are with us today in the hall St. Petersburg. Our webcast is carried out from the northern capital of Russia, St. Petersburg, and I do hope that you will not be disappointed. And today you will be able to see the best, the most innovative, the most interesting topics from the doctors, from the clinicians, from the practitioners, researchers on the most important and very different medical specialties. And let us start our session, our symposium, which is called, by the way, Endocrinology Kaleidoscope for the Internist. And that will definitely reflect the most relevant and practical topics of endocrinology. Let me introduce our first speaker, and this is Olga Fedorova, who is the chair of the task force of the Eurasian Association of Therapists, with her presentation, Myths of Thyroideology. Thank you very much, Vladimir. Good afternoon, distinguished colleagues. Before I start my presentation, I would like to say that definitely for the 15 minutes which I have been given, it's very difficult to cover all the myths in thyreoidology among our patients, among our colleagues. It will not be possible to cover everything, but let's say we will cover most frequently met myths. And in my presentation, I will present algorithms and schemes which you can take picture of and then use in your real clinical practice. I would like to say that the word myth is Greek word by its origin, and there are multiple definitions. And using this word through the prism of thyreoidology, I would like to say that this is the mystery. This is just the fantasy. Both in endocrinology and in thyreoidology, in the recent years, we faced multiple myths. Absolutely false news. They are not related even to logic and to the evidence-based medicine. Just 3 days ago, Endocrinology Scientific Center carried out the Congress, and Galina Melnichenko in her presentation covered very important term, pseudoendocrinic diseases. Pseudoendocrinic diseases. I believe that this term is directly related to our presentation today, and I would like to introduce this term to you. The term pseudoendocrine diseases was offered by Michael McDermott some time ago. Hopefully you know this book, The Secrets of Endocrinology. He wrote it, and it was very well accepted all around the world. This is his second book, Management of Patients with Pseudoendocrine Diseases. And this is not just the Russian problem. This is global problem in the US and other countries. What are the pseudoendocrine diseases? This term introduced by Michael McDermott. So this is just internet search, pieces of advice, personal trainer, friends, relatives. So the availability of endocrine disease that leads to different disorders, and they're making multiple tests. They are insisting on treatments, on those tests, on what is to be done about that. And now the speaker is muted. I think there is a technical challenge that we need to resolve. Dear colleagues, I'm pretty sure that everyone who was listening to Olga understands very clearly that this topic is extremely important. We are the victims.
И очень часто в этом смысле выступаем как раз в качестве как раз тех экспертов, которые должны поправить, изменить диагностическую, лечебную тактику. Я очень надеюсь, что вот развенчание таких мифов определит, так сказать, совершенно более адекватную, более справедливую, более точную оценку подобных ситуаций, и вас, как экспертов, как раз вооружит теми возможностями прокомментировать эти несуразицы, нелепицы, которые очень часто, так сказать, людьми далекими от темы генерируются, и таким образом это позволит нам,
and that is why it will help all of us to improve the evidence-based data, to be guided by the evidence-based data, and finally improve the curation of our patients. Well, thank you very much. So we are waiting for the speaker. Can you hear me now? Please confirm. Yes, it's okay. Well, I believe that each of you understands very clearly to what extent this topic is relevant. Hopefully, we'll be able to see our speaker in a minute. I can offer my own myths that are existing in diabetology, in endocrinology, and I think this discussion is very much relevant for each specialty, for each therapeutic area, not only in the endocrine disorders.
Да, вместе с тем мы с вами хорошо понимаем, что мне доклад Ольги Сергеевны не заменить, поэтому предоставляем ей слово.
published his second book on the pseudoendocrine disorders. And I'm pretty sure that everyone in his or her real practice is facing such patients. In my appointments daily, almost daily, we are facing such patients.
Нет. Мы вас хорошо видим, но не слышим. Нет.
Ольга Сергеевна, я вас слышу.
Distinguished colleagues, we are checking the sound. Can you hear me now?
Что нам скажет техническая поддержка? Какие следует предпринять меры?
Yes, I hear you.
Yes, we can confirm, we can hear you. Yes. So I do proceed. I would like to say that, unfortunately, all those ideas, convictions, our patients providing, and definitely they saw a lot of things in the Google, in the Dr. Google, and in the current situation, we understand that many patients are isolated, people have remote work, remote education. Many patients, all those who were not in the internet space, now they do go because they have to. And they start using these pseudoendocrinic treatments due to their wrong beliefs, wrong dogmas, wrong ideas. Pseudoendocrinic treatment is used by the people with standard endocrinic diseases, those who refuse from standard treatment and they prefer some innovative methods or increased doses or multiple tests or whatever. You definitely see these patients that found on internet some description of autoimmune disease treatment by so-called autoimmune protocols, and there they find information that they need to be treated by their autoimmune thyroiditis. So let me comment on all these myths, and very briefly. So where do we have to think about pseudoendocrinic disorders? So these people are having diagnosis in the quotation marks. So these are not real diagnoses, and there is no evidence-based data for such diagnosis. And other people, those who have proved endocrinopathies, but still having not adequate treatment, still symptomatic, those who are overused hormones, or those who are taking hazardous treatments, which is not recommended, patients having laboratory artifacts and interference. And also, I would like to refer to distinguished Galina Afanasievna and Jonathan Leffert, who is the president, American Association of Clinical Endocrinologists, AACE. This is the largest association, which is a really huge association of endocrinologists from all over the world, which with 7,500 members. He is also speaking about such internet diagnosis, problems with thyroid glands, or fatigue of adrenals. What do you think? So there are multiple patients who read these myths in the internet, and what they do is self-treatment. And let's see what the president of association, what leading endocrinologists are recommending. Don't judge them. Don't call them victims, because, you know, this is inevitable. We just talk and discuss and explain and aware and provide arguments, provide information to increase awareness. So the first myth, the need of anti-thyroid antibodies control in autoimmune thyroiditis and the treatment of autoimmune thyroiditis. Well, if we take American, European, Russian guidelines, so neither in America nor in Europe, you never ever see the algorithms of treatment of autoimmune thyroiditis, because we know very well we cannot treat this condition. Only in Russia we have very short algorithms. So what do we see here? Big diagnostic features, and combination of them allows to make the diagnosis of autoimmune thyroiditis. It can be primary hyperthyroidism, manifest or subclinical, or antibodies to the thyroid and other sound features features of autoimmune pathology. If at least of this one of these major features of autoimmune thyroiditis is absent, so if patient has just antibodies or the carriage of antibodies but not hypothyroidism, then the diagnosis of autoimmune thyroiditis is possible but not confirmed, not definitive. And we have to understand that patients, those who are carriers of antibodies, it can be 10, 12, sometimes 15% of the population, but hypothyroidism prevalence is much lower, much lower. And in developed countries, there are algorithms for the management of patients with primary hypothyroidism, but there is no algorithm for the treatment of autoimmune thyroiditis, because currently there are no methods to influence autoimmune process. And we are not using any hormonal treatment, no immunodepressants, no immunomodulators, no steroids, no drugs that prove to be efficacious in autoimmune thyroiditis. That is why the monitoring of antibodies circulating to assess autoimmune thyroiditis does not have any diagnostic or prognostic value, no value at all. And back in 2013, European guidelines speak about the same. Very briefly, I would like to talk on the comments in the American thyroid thyroxine in euthyroid patients in hypothyroidism symptoms. So on top, American guidelines, at the bottom, translation. So they strongly recommend against the use of levothyroxine treatment in patients who have non-specific symptoms and normal biochemical incidences of thyroid function, because no rule exists for use of levothyroxine in this situation. And this is strong recommendation, high quality evidence. It can be related with anemia, with iron deficiency, with vitamin D deficiency, so other conditions not related to endocrine disorders. Thyroxine to euthyroid patients in obesity, also not indicated, and moreover, this line is separately mentioned here in the American guidelines. What is the role of diet, biologically active additive nutraceutics, or autoimmune thyroiditis? Unfortunately, there is no such role, or luckily. And the Russian Association of Endocrinologists and American Dietological Association is against of any dietological recommendations. And also, no matter whether the patient has hypothyroidism or just the carriage of the antibodies. Extracts of thyroids not indicated in hypothyroidism. It was prevalent when we had no synthesized, chemically synthesized levothyroxine, the hormones of thyroid. But many of our patients, again, read the information, they scroll internet, they surf internet, they try to find some natural, herbal ways, as they call it. So thyroid extracts. Now many patients are trying to use thyroid extracts instead of levothyroxine, but in patients with primary hypothyroidism, only levothyroxine should be administered, but thyroid extracts associated with potential danger because it could be supraphysiological levels of thyroid and no data on safety. Also, we used to believe that to all patients in TTH higher than 2 to 2.5, to administer levothyroxine to reduce TTH to the level less than 2.5. So please appreciate the following, and please take a picture of this slide. I'm pretty sure it can be important in your clinical practice. So these are the guidelines of 2017. This is the tactics of thyroxine in pregnancy. This is also American TSH. If TSH is 0.1, 2.5, no need to monitor. If TSH, then we administer thyroxine. TTH, thyroid hormone, TTH. So here we have to look at the level of anti-thyroid antibodies. If antibodies are positive, then in the level of 4 to 10 of TTH, we administer thyroxine. In the level 2.5, 4, we can administer thyroxine. And if antibodies to thyroid peroxidase is negative, so with the level of TTH 2.5.4, here we keep patient treatment-free with a negative antibodies. And if TTH from 2 to 10, possibly levothyroxine can be administered. So this this is how the guidelines changed back in 2017. So please remember. And another myth that any puncture biopsy of thyroid is informative. Oh no, very frequently clinicians are getting some conclusion from pathologists where simply there is description of cells, macrophages, erythrocytes, cells of blood, but no cells of thyroid, and they don't send patients for the secondary biopsy. So please take this slide, take a picture of this slide. Let's look at who is indicated biopsy. And although we have to take into consideration the ultrasound features of malignancy, and there is a big classification according to which we can suspect malignancy of the thyroid. The recent guidelines look like this. Here they are. Puncture biopsy is indicated to those patients who have nodes in the thyroid equal or higher than 1 centimeter in diameter, and if patient belongs to the risk group for the aggressive groups of thyroid cancer, here at the bottom you see these risk groups and have some nodes with the size less than 1 centimeter. So biopsy, size of 1 centimeter or more, or less than 1 centimeter with high risk. And if description is just descriptive with no cytological diagnosis, it's not informative. We need to repeat biopsy in this case, or to refer for the second opinion this cytological specimen in more experienced morphologists, or repeat the biopsy, but in specialized medical center. And currently, we use 6 standard categories. So there is so-called Bethesda thyroid classification, first approved in 2009, when we see the punctures from the thyroid nodes. So if there is a patient, you made biopsy and you get the following data. So please take a picture of this slide as well. 6 categories of malignancy. Category 1, non-informative puncture needed to be repeated. Second, malignant, benign, only in this case, just follow-up, benign. Category 3, atypia of significant significance, secondary puncture. Category 4, follicular neoplasia, requires hemipteroidectomy to make the definitive diagnosis, and categories 5 and 6 require thyroidectomy. With that, I would like to wrap up my short presentation on the basic myths about the thyroid. So please provide your questions, comments, remarks into the comments, and I'm happy to give the floor back to our moderator. Thank you very much, Dr. Fedorova, for a very interesting presentation. Yes, well, although we had some technical challenges, but still we managed to cover the issue. Well, here into the list, I would add on some diagnoses and approaches. Another term, so-called thyroidism of tension. Thyroidism of tension, oh my God. And now, I would like to remind to all those of you who are participating in our Congress, this is St. Petersburg Hall, so you can provide your questions, comments, remarks. They would be seen in the web chat and transferred to our speakers. Our speakers will answer these questions. And now I'm happy to give the floor to the second speaker, Grigory Manushakan. He's from St. Petersburg. And this is the presentation that definitely will support the correct position presented before, because this is also important topic. This is also a topic full of myths, because lots of myths around the correct nutrition in patients with type 2 diabetes with the position of international guidelines. The presentation would be made by Grigory Manushakan, who is the lead of GP unit, MedC Premium Moscow, endocrinologist, dietologist, and clinical psychologist. The floor is yours, Grigory.
Добрый день, Владимир Владимирович. Добрый день, Ольга Сергеевна. Hello, Lauren. Glad to see you. Действительно, это очень это тема, которая, наверное, еще больше мифологизирована, чем тема, которая касается щитовидной железы. Я пытаюсь присоединить свою презентацию. Одну секундочку буквально, чтобы она появилась на экране вместе с нами. Так. Видно ли презентацию, коллеги?
Пока не видно.
Пока не видно. Сейчас,
we are waiting for the presentation.
Все
yes,
работает.
now
Отлично.
we see the presentation. Okay, it works. Perfect.
Так, сейчас мы уберем окошко, чтобы оно у нас не мешалось. Секундочку, прошу прощения. Так, Что ж такое? Не мешает просмотру презентации или все-таки есть? Вот все. Вот так вот.
Лучше убрать, Григорий.
Все, убрал, да. Итак, коллеги, давайте перейдем непосредственно к презентации. Правильное питание у пациентов с сахарным диабетом второго типа с позиции международных рекомендаций. Ну, начать надо, наверное, с того, что глобальная эпидемия сахарного диабета, слово, которое уже, наверное, давно нам приелось, на самом деле является глобальной эпидемией. И по данным IDF, на конец 2019 года в мире насчитывалось 463 миллиона больных с сахарным диабетом. И вот если сравнить с теми же данными той же самой Федерации по изучению диабета, мы узнаем, что с 2017 по 2019 год прирост составил аж 38 миллионов. Это практически 2,5 таких города, как Москва, заболела сахарным диабетом. То есть это действительно динамично развивающаяся проблема, которая захватывает практически весь мир. И смертность, мы сейчас часто говорим о смертности от ковида, она действительно удручает. Этот цикл уже превысила, наверное, цикл, который у нас смертность от ВИЧ-СПИД ежегодная происходит. Вот. Но смертность от диабета действительно намного больше. Это 4 миллиона пациентов в год, это смерть каждые 7,5 секунд. И если сравнивать с теми данными, которые у нас были, например, в 2014 году, здесь есть позитивная тенденция. В 2014 году смертность была около 5 миллионов, к 2017 году смертность снизилась на почти миллион. Это, скорее всего, связано с наличием новых классов препаратов, которые вошли в нашу практику. Это АГПП, это СГЛТ, это развитие самой медицинской помощи, в нашей стране в том числе и в мире тоже. Ну, давайте немножко отмотаем время назад и поймем, с чего все началось, что предшествовало сахарному диабету. Мы сейчас, конечно же, в первую очередь говорим о сахарном диабете второго типа, то есть о том заболевании, которому предшествовало чаще всего ожирение. И если говорить про глобальную эпидемию, то она касается, конечно, не только диабета, но и в большей степени она касается и ожирения, предшествующему развитию диабета. И в 2016 году у нас было 650 миллионов людей с ожирением в мире, и при этом почти 2 миллиарда пациентов с избыточным весом. И прирост с 60 года это плюс 325 миллионов. Это действительно очень большая проблема, и эта очень большая проблема в конечном итоге приводит к увеличению роста и сахарного диабета. Пару слов о том, как мы ставим диагноз. Естественно, мы ориентируемся на рекомендации ВОЗ и ставим диагноз на основании индекса массы тела. Но я вас призываю помнить, что индекс массы тела не всегда отражает реальную картину. Все-таки стоит, если у вас есть на приеме сантиметра, уделить некоторое время и померить объем талии, объем бедер, объем талии у мужчины или у женщины, и значение более 94 сантиметров для мужчины и более 80 сантиметров для женщины должны уже насторожить нас в отношении высокого риска развития осложнений у данных пациентов. А вот пример, почему, собственно, индекс массы тела не всегда корректен. Слева от вас молодой, всем знакомый еще, я думаю, актер Арнольд Шварценеггер, а справа менее известный молодой человек. У них абсолютно одинаковые параметры роста и веса. И формально мы должны поставить Шварценеггеру ожирение первой степени, но лично у меня бы рука не поднялась бы это сделать. Ну, а в продолжение хочу сказать, что очень часто наши пациенты говорят, что они не смогут достичь целей, которые ставят перед собой, что они не смогут снизить вес. На самом деле, если цель ставится, если есть достаточная мотивация, то, как вы видите на примере справа, достичь можно абсолютно всего. Надо помнить, что не любой жир для нас является врагом. Есть понятие подкожного жира, есть понятие висцерального жира. Это совершенно разные понятия. Есть нормальная жировая ткань, это тот самый подкожный жир, который способствует выработке противовоспалительных адипокинов, который защищает наш организм от сахарного диабета, от различных кардиоваскулярных заболеваний. И есть тот самый патологический висцеральный жир, который как раз способствует выработке провоспалительных адипокинов и снижает выработку противовоспалительных адипокинов, то есть снижает защиту нашего организма, вызывает низкоуровневое воспаление, вызывает развитие метаболического синдрома, кардиоваскулярных заболеваний и сахарного диабета второго типа. С чего начинаются все рекомендации по лечению сахарного диабета? Какую бы рекомендацию мы ни взяли, российскую, американскую, европейскую, по диабету, по лечению гипертонии той же самой, да, все начинается с одного и того же. Нам говорят о том, что надо менять образ жизни. И каждый раз, когда фраза про изменение образа жизни появляется передо мной, у меня лицо, как у практически у Роберта Дауни-младшего, известном меме, потому что такое изменение образа жизни очень часто не объясняется. Или ставятся какие-то абстрактные флажочки, по которым мы должны ориентироваться, надо снижать вес, надо отказываться от вредных вредных привычек, надо увеличить физическую активность. Как это сделать? Как заставить нашего пациента сделать? Вообще стоит ли заставлять? Ну, давайте посмотрим, что рекомендуют международные эксперты. И начнем мы со стандартов медицинской помощи АДА 2020 года. Первая рекомендация. Всем пациентам с сахарным диабетом рекомендуется изменение образа жизни для достижения поддержания минимальной потери веса 5%. И к этой цифре мы еще вернемся. Для лечения диабета допустимы различные режимы питания. Как вы видите, нет единой диеты, которую бы мы могли предложить нашим пациентам и быть уверены, что мы получим желаемые результаты. Ну и также не существует единого идеального диетического распределения калорий, белков, жиров и углеводов, поэтому план питания должен подбираться индивидуально для каждого пациента. Персонифицированная медицина во всей красе, собственно, должна быть задействована. Вернемся к вопросу потери веса на 5%. Когда вы пациенту, который приходит к вам, ну, в данном случае я выступаю не только как эндокринолог, но и как диетолог и клинический психолог, это дополнительное мое образование. Так вот, когда приходит к вам пациент для снижения веса и спрашивает, ну, доктор, сколько я могу снизить вес? И вы говорите, ну, минимально это 5%. Он весит 100 килограмм, он так думает, говорит, ага, то есть я могу сбросить 5 килограмм. Вы знаете, 5 килограмм я могу сбросить и сам за выходные, просто не поев белков и не выпив алкоголя, и посидев на кефирной диете, условно. А на самом деле, что такое снижение веса на 5%? И что такое вообще снижение веса? Это снижение и удержание веса. И вот если мы снизили вес на 5%, смотрите, сколько профита мы сразу получили. Снижение риска диабета, снижение сердечно-сосудистой смертности, улучшение липидного профиля, улучшение показателей артериального давления, снижение тяжести, течения обструктивного апноэ и, естественно, как итог, улучшение качества жизни. Поэтому каждый лишний сброшенный килограмм – это всегда позитивная информация, это всегда позитив для пациента. Мы не стремимся к каким-то абстрактным огромным цифрам, да, нас интересуют реальные цифры. Ну и опять же говоря о том, какие варианты питания рекомендуют наши международные эксперты, сначала мы условимся о том, что такое порция, потому что понятие порция возникает регулярно в различных диетах, в различных рекомендациях по питанию. Итак, что такое одна порция фруктов? Это, собственно, один фрукт, одно яблоко, одна груша, один апельсин. Что такое овощи? Одна порция овощей – это 80 грамм овощей, либо, например, десертная миска салата, либо 3 столовые ложки сырых овощей с горкой. Итак, начнем мы с самой изученной, самой любимой всеми международными ассоциациями диеты – это средиземноморская диета. Самая изученная она потому, что на ее тему уже исследований прошло более 3000, это еще данные 2015 года по поводу 2800 исследований, 8 метаанализов, 5 рандомизированных исследований. И что нам говорит эта диета? Если мы ее соблюдаем, то мы получаем почти в 2 раза снижение риска, на 50% практически снижается риск метаболического синдрома. Мы снижаем риски смертности, мы снижаем смертность от ИБС, мы улучшаем контроль гликемии и улучшаем контроль за липидами. Поэтому диета действительно полезная, диета очень интересная. Вот так она выглядит, если использовать ее в режиме пирамиды питания. Да, все равно в основе у нас лежат углеводы. Это цельнозерновой хлеб, это и паста, и пшено, то, что, кстати, наши пациенты очень часто исключают из своего рациона. А это питание для диабета, для лечения диабета в том числе, да, не только для снижения веса. Это фрукты, это бобовые, что у нас сильно ограничено. А сильно ограничено у нас красное мясо. Так обычно ведет себя любой среднестатистический пациент, когда он пытается снизить вес. Он переворачивает эту пирамиду с ног на голову. То есть в основе у нас много белка, чуть поменьше жира и минимальное количество углеводов. Это и те же кето-диеты, это различные диеты там, Дюкана или другие, любые высокобелковые диеты, низкоуглеводные диеты, они выглядят именно так, как перевернутая пирамида средиземноморской диеты. И, к сожалению, долгое время пациенты не могут соблюдать эту диету, потому что низкий уровень углеводов в конечном итоге приводит к различным жалобам в виде слабости, вялости, сонливости и в конечном итоге еще и обратной прибавки веса. Поэтому диета средиземноморская достаточно корректная, ее можно использовать, если есть такая возможность. Не у всех, понятно, что есть такая возможность, если отъехать от Москвы там, на 300 километров, не в каждом селе будет возможность выбрать качественные продукты, которые здесь представлены. Второй вариант питания – это диета DASH, Dietary Approaches to Stop Hypertension. Это диета, которая, естественно, как понятно из названия, помогает и призвана для нас снизить риски, связанные с гипертонией. Но помимо того, что она помогает облегчить контроль за уровнем артериального давления, она еще и достаточно качественно снижает уровень сахара. Помимо этого, замедляет развитие остеопороза, онкологических заболеваний, снижает уровень мочевой кислоты и липидов в крови. То есть замечательная диета относительно всех осложнений, которые могут возникнуть при сахарном диабете. В чем ее плюс? Ну, посмотрите, вот как раз мы говорили про порции фруктов, нам нужно аж 5 порций фруктов, 5 порций овощей, можно и белки, можно и зерновые продукты. Ну, жидкость здесь не надо смотреть на апельсиновый сок, соки как раз пациентам с диабетом лучше не употреблять. Но есть и минусы. Первое, это, так как это диета для снижения артериального давления, в первую очередь, то, конечно, очень сильно ограничена соль, до 1,5 грамм в день. Ну, а второе, самое главное, что, наверное, ставит крест на ней для большинства пациентов в России и странах СНГ, наверное, тоже, это полный отказ от алкоголя. К сожалению, не все пациенты готовы на это пойти. Ну и третий вариант диет, который тоже также рекомендуют международные эксперты, это диета MIND. И здесь MIND это не просто сокращение, это как раз отсылка к тому, для чего эта диета создана. Появилась она относительно недавно, в 2015 году, и является симбиозом средиземноморской диеты и диеты ДАШ. Так и странно, и диета, которая помогает нам снизить вес, и диета, которая помогает нам снизить артериальное давление, мы получили диету для снижения риска болезни Альцгеймера. Вот такое вот интересное наблюдение, причем достаточно хорошее снижение риска болезни Альцгеймера, аж на 53% у пациентов, которые строго соблюдают эту диету, и на 35% у пациентов, которые не строго соблюдают эту диету. Снижается риск развития деменции, замедляется снижение когнитивных функций, и самое главное, снижается накопление бета-амилоида и образование бета-амилоидных бляшек, а именно они провоцируют как раз развитие болезни Альцгеймера. Если углубиться немножко в диабет, есть исследования, которые показывают, что этот бета-амилоид также накапливается в бета-клетках и, собственно, затрудняет их работу, приводя к ликвидации сахарного диабета. Ну, это исследование экспериментальное, в основном на ушах, поэтому помнить об этом нужно, но не обязательно верить здесь на слово. Снижается выраженность окислительного стресса и, самое главное, то самое воспаление, хроническое воспаление, которое есть у всех наших пациентов с хроническими заболеваниями, точно так же снижается. Можете сфотографировать эту диету, это ту диету, которую можно как раз рекомендовать нашим пациентам, потому что она достаточно простая в рекомендациях. В правом нижнем углу есть ссылка, если вы хотите более подробно про нее прочитать. Давайте остановимся на том, что нельзя, потому что много чего можно. Мы ограничиваем красное мясо до 4 порций в неделю, то есть 3-4 порции, это как раз согласно средиземноморской диеты. Мы, естественно, ограничиваем сливочное масло. Ну, здесь речь идет менее 1 столовой ложки в день. Я бы сказал, наверное, 3 раза в неделю грамм по 10 вполне достаточно для того, чтобы получать пользу, но не получать при этом вред. И смотрите, такое жесткое ограничение по продукту по сыру. Да? Высокое количество белков, высокое количество жира в этом продукте не дает нам возможности его постоянно рекомендовать, и здесь даже реже, чем раз в неделю. Сладкое. Не надо полностью отказываться от сладкого пациенту с сахарным диабетом. Не стоит прибегать к продуктам, богатым фруктозой, и заменять сладкое на фруктозсодержащие сахарозаменители. Совершенно не стоит этого делать. Фруктоза ничем не лучше глюкозы. И в данном случае вы можете договориться с пациентом о том, какое количество сладкого конкретный пациент будет получать в день, употреблять тогда, когда ему хочется. Ну, например, это будет пастила, которая сделана натурально из яблочного пюре с пектином, то есть близкое к натуральному. Либо это темный шоколад, может быть, в разумном количестве, который пациент свободен употреблять в течение дня. Ну и, конечно же, ограничен фастфуд. Тут, я думаю, так понятно, почему. И вот, так как наши пациенты с диабетом, в общем-то, склонны к различным проблемам с деменцией, то употребление именно такой диеты не только поможет контролировать сахар, но и поможет снизить риски развития деменции. Ну и, конечно же, рекомендации... Заканчиваем. Еще 4 минуты. Ну, даже 3, наверное.
3 more minutes.
Меньше, хорошо, заканчиваем. Рекомендации по физическим нагрузкам, они достаточно простые, да, до 150 минут умеренных аэробных нагрузок в неделю и 75 минут интенсивных нагрузок в течение той же самой недели. Это буквально 25-30 минут в день. Не так уж и много. Целевое количество шагов 10 тысяч. Мы должны помнить, что все это должно работать вместе с изменением питания. Как пример, одна съеденная картошка, 15 минут бега, 20 минут плавания, 15 минут похода на этаж, да, или 3,5 часа сна. Поэтому сон очень важный момент, менее 7 часов сна, это плохо для наших пациентов. Ну и я сокращу момент с эмоциональными состояниями. Просто хочу напомнить вам, что у пациентов есть определенный психоэмоциональный аспект нарушения пищевого поведения, пациенты с лишним весом, поэтому они периодически будут срываться с питания. Это нормальная история, нужно с ними это проговаривать, нужно говорить о том, что они должны чувствовать чувство вины за стресс, они должны просто возвращаться к своему обычному питанию. Ну и есть различные типы нарушений пищевого поведения. Эмоцигенное – это срывы, связанные с эмоциональными перепадами, заеданием стресса. Экстернальное – это когда какой-то вид пищи провоцирует на нас на ее прием. То есть не увидели хлеб, не съели, увидели хлеб, съели. Ну и ограничительный тип пищевого поведения не очень характерен для пациентов с диабетом. Вы можете сами своих пациентов найти тип нарушений даже у себя, посмотрев, пройдя онлайн так называемый голландский опрос. Ну, про круг эмоционального передания, наверное, рассказывать уже не буду, потому что мы вышли из графика, я думаю, у нас 20 минут есть. Ну, хорошо. И подойдем итог. Рекомендации по пациенту для пациентов с сахарным диабетом – это изменение образа жизни, это отказ от вредных привычек, повышение физической активности, нормализация сна. Это контроль за гликемией, артериальным давлением, липопротеидами низкой плотности, гликированным гемоглобином, динамический контроль, естественно, коррекция питания, снижение массы тела минимум на 5-7%, но не более чем на 5 килограмм в месяц, и ежегодное диспансерное наблюдение под контролем врача, ведущего эндокринолога. Спасибо за внимание. Владимир Владимирович, передаю вам слово.
I'm giving the mic back to the moderator. Thank you very much. Very informative, very practical report. And I think that really we made a very important aspect because Grigory drew our attention that definitely when we talk about the diet, when we talk about the correct nutrition, possibly we should always put correct accents because correct nutrition in diabetes, it's not just carbohydrate-free nutrition. No, it should contain carbohydrates, but specific carbohydrates with specific amounts. And moreover, we need to understand that really compliance in between the patient and the doctor is extremely important. It's always beneficial and helps to obtain optimal results, correct nutritional approaches. And we should always remember that our interaction with the patients should be continuous, permanent, and preferably regular and rather frequent. And now let us move to the next speaker, and let me introduce our international expert, our dedicated guest, our greatest friend, friend of the Eurasian Association of Therapists, Goran Cvijic. And Goran will present Belgrade, Serbia, and he is a global expert, a doctor of medical science. He is working as endocrinologist in endocrinology and diabetes and metabolic diseases and obesity center clinic. And very frequently, he is the part of the international congresses, symposia, and the topic of his presentation today is the glucose and bone metabolism, possible interactions. I believe this is new interpretation and this is a new view about the possible interaction. Goran, can you hear us? Please unmute, show your slides and speak up.
Hello, Vladimir. Do you hear me?
Добрый день, Владимир. Меня слышно?
Да, слышно.
Hello, do you hear me?
Yes, please proceed. Please share your slides.
Okay. So.
Итак.
Okay.
Ну что ж.
Hello. First of all, I am sending you warm greetings from Belgrade, and I must say that I am very glad that I'm again a part of your team and very glad to participate at your conference. During these brief presentations, I will just show you a few data about the loop or connection between endocrine pancreas function and bone metabolism. I will start with the impact of diabetes on bones. And here on this very nice meta-analysis, you can see that patients with both type 1 and type 2 diabetes had increased fracture risk. Of course, this fracture risk is significantly higher in patients with type 1 diabetes in comparison to patients with type 2 diabetes, but it exists in both types of diabetes overall. We know that approximately 90% of our patients with type 2 diabetes are abdominally obese, and this is a very fine cohort study from Norway suggesting us that abdominally obese patients are at a significantly increased risk for hip fracture. As you can see, as the waist to hip ratio rises over the normal, this risk is very powerfully going up. So this is also maybe one of the things that increase the risk for fractures. When we say something about bone fracture, the first thing we think about is bone mineral density, or BMD. And we can see that in patients with type 1, there is a significantly reduced BMD in comparison to the normal population. Also, in patients with type 2 diabetes, as we can see, there is increased fracture risk, but the bone mineral density is normal. This analysis of the postmenopausal woman with vertebral fractures are showing us that women without diabetes have a nice correlation between age and BMD and the risk for fracture. So if you are older or if your BMD is lower, the fracture risk is increased, while in a woman with, in women with type 2 diabetes, there is absolutely no correlation between age or BMD or fracture risk. So where is the problem? This is very nice definition or theory actually showing us that patients with type 2 diabetes have normal bone mineral density, but the quality of the bones is poor. What the speculation is that it is due to the position of the advanced glycated end products, or AGE, and their receptors that inhibits function of the osteoblasts, actually inhibits production of the osteocalcin and inhibits the synthesis of the matrix and collagen type 1. We'll see if this theory is correct. Here is in vitro studies, and here in this first column, you can see that media with osteoblasts with normal glucose has normal function of the osteoblasts and normal production of osteocalcin. If we increase the glucose concentration, we can see that this function of the osteoblasts is reduced almost for 50%. If we add to the osteoblast insulin or the vitamin D or both, we will significantly improve the quality of the osteoblasts and finally increase the production of the osteocalcin. So is this in vitro study can be translated to the in vitro results? And we shall see now, this is one population study also showing us that patients with type 2 diabetes have significantly lower osteocalcin level in comparison to the patients with normal glucose tolerance. And what we also can see from the further analysis is that osteocalcin levels are absolutely correlated with fasting plasma glucose and HbA1c. So there is a potent correlation between acute level of glycoregulation and chronic glycoregulation. This is for overall patients with diabetes, and in patients with type 2 diabetes, we can also see that there is a negative correlation between osteocalcin levels and the fasting blood glucose or HbA1c, so acute and chronic glycoregulation. Definitely, the level of glycemia interact with osteoblast function and definitely inhibits it in the bones. But is the glycoregulation everything? We know that our patients with type 2 diabetes also have a very complex metabolic profile. And in this study, it was shown that not only the level of glycemia, but also the level of insulin sensitivity, and that is here assessed as a HOMA index, and the level of chronic inflammation here assessed as a high sensitivity, have more components of the metabolic syndrome. This is, we must know that this is only a population of patients with type 2 diabetes, not a normal population. So if we have in vitro results, if we have in vivo results, what will happen with cardiovascular outcome? Shall we confirm these results? And here we can see this is a study where the classification score of aorta was evaluated, and it was shown that if the people, or actually in this case only the men, if the men had lower osteocalcin levels, the higher score of classification of aorta was observed. And the most striking result in this study is actually that osteocalcin was the most important predictor of the classification of the aorta. Here you can see other standard risk factors such as BMI, HbA1c, HOMA, etc. But there was no correlation between these standard risk factors and the level of calcification. So can we find or observe the same results considering other blood vessels? And here also it was shown the significant negative correlation between osteocalcin level and intimomedial thickness of the carotid artery. So beside all the other factors such as age, sex, systolic blood pressure, and lipids, osteocalcin was one of the most important predictors of intima-media thickness. In a recent few years, there was some study analyzing the correlation between osteocalcin and coronary heart disease, but the results were negative. But as I saw, as I say previously, osteocalcin is not the only hormone from the bones. Here, one very important hormone is osteoprotegerine, and as you can see here, it is independently associated with the severity and the extent of coronary heart disease. It is strongly predictive of all-cause mortality in diabetic patients and predictor of long-term mortality and heart failure. But I must say again, think this only in patients with type 2 diabetes. We saw that definitely endocrine pancreas acts at the level of the bones, acts about on the activity of osteoblasts and its endocrine function. But is there any back loop, actually the back direction from the bones to the endocrine pancreas? And this is one of the maybe revolutionary slides from two very famous endocrinologists, showing us that, as you can see here, this GPRC6A receptor, it is a receptor for osteocalcin, and it is located at the beta cells of pancreas. It activates cyclin D1, and as you can see, it induces proliferation of the beta cell mass at the pancreas. Why is this important? It was shown that the activity of this receptor is very strong during fetal period and early neonatal period. And the level of osteocalcin is also very high in that period. And they speculate that actually level of osteocalcin during fetal and early neonatal period will induce our peak beta cell mass. So it will determine the overall beta cell mass that we will have later at our life. So also there is a study, but not at humans, on the mice, showing us anti-hyperglycemic effect of the osteocalcin. In this study, it was shown that administration of the osteocalcin, oral administration, reduced fasting and stimulated glucose. It increased basal insulin levels. And the very important thing is that it was shown that osteocalcin effect is not only due to effect of its receptor on the beta cells, but also it acts on the L cells at the balls, and it produces GLP-1 production. Both GLP-1 and osteocalcin increase beta cell mass or beta cell area in the endocrine pancreas. So we do not have much time, but here you can see that osteocalcin interact not only with endocrine pancreas, it acts at the level of muscles and fat tissue, improving insulin sensitivity, increasing the level of adiponectin. It acts directly to the testicles and produce testosterone and increase sperm count. So finally, I will finish with this slide showing us that endocrinology is not the connection only between endocrine glands. In recent years, we saw that adipose tissue is also an endocrine organ. Now we see the bone is also endocrine organ. And what will happen tomorrow? Is the heart, lungs, or any other organ in our body also endocrine organ? So I would like here to encourage young colleagues to look at the bright future and to become endocrinologists. Thank you.
Thank you very much, Goran, for a very interesting presentation. I totally agree with all your messages, especially the last one, that endocrinology is the science of all the sciences. And this is a very perspective specialty for the young doctors. And that was very interesting to know more about this very new, interesting loop between the osteocalcin and metabolic health of the diabetic patients. And yes, this is something new, something totally new. And I'm pretty sure that in a very short time, we will be able to learn more about this potential marker that possibly guides and controls lots of changes and is related to many correlations in metabolism in our patients. So thank you very much. And now let me introduce our next speaker and the next presentation. And this is my presentation. I will speak on the link of androgen deficit and cardiovascular risks. And I think this is also important. It continues the topics that has already been covered by Goran in his presentation, specifically to find some correlations with other parameters of the level of testosterone, which is endocrinologically typical for us, and to find this link between testosterone and cardiovascular risks. So hypogonadism or androgen deficiency, this is a condition that we normally identify as clinical and biochemical syndrome, which is related to the low level of testosterone or reduced sensitivity to the receptors that leads finally to the negative influence on multiple organs and systems, and the most important, it is reflected in the reduced quality of life and life expectancy. The most important is that here we will cover the functional part of androgen deficiency, not the organic one. And in this part of functional disorders, functional hypergonadism, I would cover mainly transitory androgen deficiency in healthy males, then androgen deficiency in males with chronic diseases, and age-related androgen deficiency. And our chair number 1, named after academician Molchanov, is dealing more than 50 years with issues of transitory hypergonadism. This is the understanding, this is the representation we are having for many generations of experts, specialists, researchers who study this issue. And what is transitory hypergonadism? This is exactly the temporary functional reduction of testosterone with the diseases of endocrine system, with the liver and renal dysfunction in acute conditions, with the emergency factors, and with the use of drugs. It is believed that this type of hypogonadism does not require independent treatment because the androgen secretion can be recovered after the particular conditions, after rehabilitation. The godfather of this phenomenon with the external risk factors influence is Professor Shurigin, our former chair lead, and then It was continued by academician Mazurov, who will speak up today, later in our hall after lunch, in rheumatoid diseases section, who studied the condition of endocrine system with influence of such emergent factors like high mountains, long-term physical exercise with low calories when they prepare to their astronautic flights, and in hyperkinesis. So it was found out that under this condition, transitory hypogonadism really resolves simultaneously and does not require any additional replacement approaches. Professor Yakovlev will continue this work and studied androgen deficiency in the Antarctic expeditions and showed that the increase of LH in winter means a particular reduction of testosterone in autumn. In the 19th Antarctic expedition was found like a particular consequence of the conditions in the adaptation. Professor Shustov also showed that hypogonadism that is formed under the conditions of acute MI can be restored in a number of cases after the infarction. But in some patients, it can persist, and most probably suppression of hypogonal system is linked to the severity of heart failure that can be obtained and the heart rate disorder. The same trends were shown by Professor Rakov, who in fact confirmed the reduction of testosterone in burns, in patients with burns, and also it was confirmed by the next investigator, Dr. Pugachev, who also confirmed that burn trauma reduces testosterone in males and reduces functional and causes androgen deficiency. In a number of further publications, specifically the works of Professor Kharitonov, it was shown that androgen deficiency in this serious exacerbation of asthma can be persisting, and the replacement treatment never changes the main disease, specifically bronchial asthma, but improves quality of life and the life tone of the patients. So speaking about the functional androgen deficiency, we can conclude the following, that this is adaptive reaction, which is typical for the healthy males, and it does not require an intervention in healthy males, but can be premorbid. So if there is androgen deficiency in males with acute diseases, we can speak that it can be of some pathogenetical significance. The question about the replacement treatment is not yet resolved. It's a big question yet. Probably this is our future. This is what we are going to study. And let me speak a few words about the chronic age-related androgen deficiency, because it has its own pathogenetic significance, and there is multiple proof to that and multiple trials carried out on that. We know very well that age-related androgen deficiency is definitely very frequent condition. This is biochemical and clinical condition. And in the studies, it was shown that every male age 30 plus starts demonstrating the level of androgen reduction by 1%. And such diseases like diabetes, like obesity, like hypertension, like dyslipidemia facilitates this reduction. And this is how it can lead to the early androgen deficiency. And in this term, the word age-related deficiency, it's not the definition of age. This is the definition of the trend that characterizes this reduction. So we understand that androgen deficiency, this is really a complex condition, which is characterized by very diversity, very heterogeneous clinical picture. So these patients are coming to multiple specialists, but there is very important triad carved in stone, and it helps us to look at the clinical symptoms. When it's a reduction of libido, sexual activity, this is reduction of morning erections and reduction of adequate erections. So this triad, which is carved in stone, can be identified in diagnostic stages through the questionnaires, through the laboratory studies, that mainly guided by the level of testosterone, and at the same time, testosterone less than 12 nanomole per liter plus clinical manifestation. This is the basis for extra examination, because in this case, we need to perform globulin binding sex hormones and estimate the level of free testosterone. And if there is general reduction of total testosterone less than 9 nanomole per liter, we need to measure gonadotropic hormones and prolactin. Well, this questionnaire is, you can take a picture of this slide. It can be very useful. This is a very clear approach, very user-friendly, very simple, very practical. So there are multiple calculators that can help you to count, and this is free and available testosterone calculator from the web. And what is the basis for testosterone screening? These are the latest recommendations. All age males with multiple features of androgen deficiency, of male with erectile dysfunction, loss of spontaneous erection or low sexual libido, diabetes type 2 with BMI more than 30 or with waist circumference 102, and those who have taken antipsychotic or anti-seizure treatments, anti-epileptic treatments. And we are not making any conclusions. We are not making the diagnosis if we don't have at least two tests with difference of 4 weeks correctly performed, early morning hours, not in the acute period of the disease, because we understand that it can be transitory functional androgen deficiency, which smash our understanding, which dilute our understanding, or decompensation of the chronic disease. So why do we believe that it is so important? Because the reduction of testosterone level directly associated with the increased components of metabolic syndrome, as you appreciated here. And this is famous and classical study, Norfolk study, showed that cardiovascular and all-cause mortality is indirectly proportional here to the level of testosterone. The lower testosterone, the higher is mortality. It was shown in the animal studies, castrated animals, where with the replacement with androgenic treatment and replacing after surgical castration, this function by exogenous testosterone showed the same characteristics of lipids and total cholesterol like control groups, so those animals that were not castrated, which proves again that testosterone surely is the agent that is a must for the adequate lipid profile. And here we can appreciate that in all the curves, top line, it's almost always control. The other study, this is big clinical trial. We can appreciate that testosterone is related to dyslipidemia, and patients have more dyslipidemia with lower testosterone. Now, link of testosterone with ischemic heart disease was also demonstrated in our chair in collaboration with the Central of Adrenal Pathology, where we showed that by coronary graft data lower than 9 nanomole per liter, they characterized more severe involvement of coronary arteries. And androgen deficiency is characterized by strong negative correlation with the level of free testosterone and total cholesterol level. Also, such patients are characterized by the reduction of left ventricular fraction and longer duration of painless ST segments. And patients with androgen deficiency this way are the patients who would be characterized asymptomatic angina attacks, and we can be confused by their cardiovascular events and the assessment for them. And in big meta-analysis, it has already been shown that low level of testosterone is a marker or even a factor risk of cardiovascular diseases and mortalities. How do we provide a replacement therapy of testosterone? Well, indications here, this is everything which has been mentioned before. This is correction of the clinical manifestations, this is reduction of libido and reduction of erection. So that the triad, basic triad that we are based on. Then deficiency of muscle mass and patients with verified hypogonadism. Contraindications, definitely well known. Here it's prostate cancer or breast cancer in males, or males with active desire of fertility, high hematocrit, and chronic heart failure, high grade by NIHA. And with replacement treatments of testosterone, we are getting lots of metabolic effects. So pretty prolonged period. We need to give time. We need to give time for these effects to develop, to progress. But this is complex influence to the muscle mass, fat-free mass, reduction of fat mass in the obesity of the patients, reduction of waist circumference, and other metabolic parameters that would influence very positively to the metabolic profile of our patients. And if we administer testosterone treatment, would it influence? Would it influence cardiovascular risks? Appear to be yes. In diabetic patients, it has already been proved, but with diabetes. And here, the lower curves that characterize less mortality. These are those patients who were getting testosterone versus those who were not. They were characterized by high levels of mortality. So what levels of testosterone are target one in the replacement therapy? So normally, this is average normal range. We should not go too high or too low of testosterone because it will guide the increase of cardiovascular risk. So in average, it is recommended from 15 to 20, from 15 to 20. So these are the current guidelines. And these are the target levels for testosterone. Well, definitely in patients with diabetes, so normally these patients of very high cardiovascular risks here, we need to pay attention to that. We need to screen patients properly to the hypogonadism, and this is how to correct if we identify this finding. So deficiency of testosterone and cardiovascular disease is definitely associated in between, but unfortunately yet we do not see serious evidence-based data, no epidemiological studies that could find this relation. And here you see, as it's recommended in the majority of the professional communities, associations that study male hypogonadism, that we need large trials to study possible cardiovascular outcomes. Well, and this trial has already been designed and ongoing. This is TRAVERSE trial. This is first randomized placebo-controlled study to assess frequency of cardiovascular events with testosterone. So that was started in 2018, and we're expecting the results in 2022. So transitory androgen deficiency does not require any treatment because we are hoping for the recovery. Age-related androgen deficiency should require correction, and association of testosterone with ischemic heart disease and diabetes with androgen deficiency would be characterized with higher cardiovascular risks and mainly would be manifested in the elderly male group. And definitely androgen deficiency, it's a reason for proper cardiological study, and testosterone replacement therapy is safe and can positively influence different metabolic parameters, and further studies will hopefully prove where testosterone can influence cardiovascular events in adequate evidence-based data. With that, I would like to finish my presentation, and let us go to the discussion, which was scheduled after this session. And I repeat for those who just joined us that right now we are going to cover some practical endocrinological issues because our session is devoted to the endocrinological aspects for the internists. So we have accumulated a number of questions. So first question to Grigory. Grigory. Well, I will simplify the question a little bit because it is very long. So Grigory, what do you think? In case when we talk about the patients with type 2 diabetes, can we recommend, if a patient is taking non-hypo-reducing drugs, the nutrition in the scheme 8 to 16? Yes, probably the question is about very famous approach when it's not the diabetic patient, but just to harmonize the nutrition. They use the approach 8 to 16, so 16 hours between the meals, 16 hours between the meals. So 16 hours from the last one up to the next one. Can we use it in the diabetic patients? Well, thank you very much for the question. Question is very interesting on the one hand. On the other hand, yes, there were studies when the patients who already had anti-hyperglycemic treatment were switched to the low carbohydrate diet, less than 1,000 kilocalories plus physical exercise, and control group was hypoglycemic treatment and some general recommendation for weight reduction. So in the group of patients who just, definitely that was not very high glycemia surely, but that group went into remission for several years. If they stick full-fledged, very stringently, that diet, 16 hours in between the last intake and the next day intake, but patients were over the continuous control, regular follow-up, and the results of weight reduction were 3 times better versus the group with anti-hyperglycemic treatment and general recommendation without close monitoring. So that means, yes, we can get, honeymoon and then, to move away from anti-hyperglycemic treatment, but with very, very strict diet, very strict diet. But let's look at this diet. This is interval fasting. And there are different options, 16-8 or every 24, most stringent one. So this is a nutrition which may not meet every patient because there are different lifestyles. That's first. Second, this is interval nutrition which facilitates what patients are going to eat inside these 8 hours. This is also very important because it can be wrong nutrition during 8 hours of nutrition. And let me briefly finish the answer. If you can extrapolate the type of nutrition that you believe to be optimal for weight reduction for the rest of the life, that means the results on the weight reduction and the reduction of glycemia, that would be long-term, sustainable. But if you understand that this diet cannot last long by a number of reasons, you will simply cannot stick it longer than 3-5 months, so please don't start. Don't start, because finally you roll back to the baseline level, your normal nutrition, with the same sugars, with the same weight, and to the initial result without any improvements. Let's say I'm against, more against than in favor. Well, thank you very much. We have another question. This question is about Olga's presentation. Olga with us. Olga, you talked about myths and you spoke about one aspect. You said that nutrition is also a myth with thyroid diseases. And one of the doctors is asking, what is your attitude to the use of zinc? Because the last few years, we saw many publications about the benefits of zinc for the patient with thyroid diseases. Thank you very much for your question. Olga, we cannot hear you, please. Yes, now we can hear you. Yes, thank you. Thank you very much for your question. And I would like to refer to the guidelines of ADA, which are telling us that still, unfortunately, yet we do not have enough data on the use of any drugs, whatever, zinc or selenium. Yes, there are small publications about that, but we don't know much. So according to the guidelines, we should not use anything like that, neither for the prevention of hypothyroidism, if there are antibodies, or in case of developed hypothyroidism with autoimmune thyroiditis. So the only treatment is replacement by levothyroxine if hypothyroidism is diagnosed. And the only tactics is follow-up if there are anti-thyroid antibodies. That's it. Well, thank you very much, Olga. Well, distinguished colleagues, we have no more questions in the chat yet. And wrapping up our discussion and wrapping up our symposium, let me thank our distinguished experts who were providing very interesting, innovative presentations with novel data covering all aspects of endocrinology that we can be guided by in our clinical practice. This is what we frequently use. And with that, we complete our session, we close it, and now we deserved 15 minutes break. And After a short break, if I'm not mistaken, we will continue in this hall. So we will continue with a new session, which will be presented by the family medicine of Northwest University, named after Mechnikov, and we will speak about the pathology of the elderly. So, dear colleagues, welcome back at 2 o'clock Moscow time, and we will get very interesting presentations and the continuation of the scientific program. With that, we close symposia. Thank you very much. Have a good day and goodbye.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
Distinguished colleagues, we do proceed our 10th International Congress of the Eurasian Association of Therapists, and we proceed in the whole St. Petersburg. Here you are, and this is here where we continue discussing the issues of St. Petersburg Therapeutical School. Specifically, we are talking at the symposium covered by the family chair of Northwest Medical University named after Mechnikov. And let me announce this symposium. And I think it sets a very good stage for future discussion, very good discussion. It is called Challenges of Providing Care to Elderly Patients in the General Medical Practice. And let us start with symposium with the presentation of the lead of the Family Medicine Chair, Professor, Doctor of Medical Science, Olga Kuznetsova, with her presentation of a clinical case. Patient age 90, after stroke and the proximal femoral fracture. The floor is yours. You're welcome. Good afternoon, distinguished colleagues. Let me introduce this case. This is exactly the case we faced in the morning medical conference in our family center when the young doctors were reporting about the cases administered at night. So this patient is 90. 3 years ago, ischemic stroke, hemoptysis, aphasia, followed up by the family medicine center. Patient is followed up for many years. Hypertension now is properly controlled after the stroke. But 2 months ago, patient fell down and proximal femoral fracture, and patient is immobilized. So his daughter is caring about him, and she is very much concerned that her father refused from food, from any meals, although before that he never suffered from the loss of appetite. So what should family doctors do when we see such patients? So why is he refusing from food? Maybe hypertrophy, dehydration, and how dangerous anorexia to these frail patients, maybe cognitive disorders, maybe pressure ulcers, although it's anti-pressure ulcers mattress, but still maybe there is pain, low physical activity, any features of constipation, and very important issue, how to prevent falls and fractures at such vulnerable, frail age. So we should ask multiple questions of care about these patients, how we should provide the nutrition, how much fluid. Maybe there is a desire of the patient. Maybe a patient does not want to eat that food which is cooked by his daughter, how she is carrying his skin, maybe minimal physical activity is supported, and how the body position is changed in bed. So these are all important issues of preventing pressure ulcers. So we need multidisciplinary team. How can we resolve it? Definitely, we need a geriatric support, because geriatric support can help us to find out geriatric syndromes at home, and we know this is a mission, and we have the order of providing medical care on the specialty geriatry. You could be neurologist or palliative care specialist or rheumatologist. So we had consultation from a geriatrician. She emphasized that there is very high prevalence of malnutrition in elderly patients, and there are 3 grades of malnutrition, which are presented here on the slide, from mild up to severe grades of malnutrition. And also she drew our attention to the fact that via clinical assessment of the patients, we are able to suspect malnutrition in this case. This is the loss of soft tissues, also interbone muscle between the thumb and pointing finger, alopecia, depigmentation of skin, lower healing, reduction of cognitive capacities. So all these issues we have to pay attention to when we assess such patients. Besides, xerostomia can be one of the malnutrition reasons, and even reduction of appetite. It can be seen in 20% of elderly patients, and it has very clear manifestation, which is dry mucosa, ileitis, erosions, and also fungal infections, which is additional risk factor specifically for anorexia. Palliative care specialists also gave a tip to a young family doctor that currently there are new orders of managing such patients. They are confirmed by the Ministry of Health order. And for our audience, I'm giving you the link to this order of the Ministry of Health. And our patient absolutely meets to the principles of palliative care, because there is paralysis, there is function loss, there is speech disorder. Why do we have to remember about that? Because we need to create medical concilium, because according to the results about the need of their palliative care, it would be much easier to get access to different rehabilitation tools and drugs for free. And besides, as this is a patient with a stroke, we should refer this patient to neurologists. And neurologists said that multiple reasons of refusal from food, it could be bulbar syndrome, pseudobulbar syndrome, dementia, depression, neurotic disorder of neurology, also pain or burning in the tongue and loss of tongue sensitivity. Also, it could be symptoms of dysphagia, shown here on the slide. These are features of poor speech quality, cough or before or after food, then spitting out, respiratory problems. But the only thing what we saw is a loss of interest to food, poor appetite or refusal from the food. We couldn't understand the reason, but our consultant reminded us what should be the correct nutrition of these patients, and it should be known by the doctors and caregivers, only in a sitting position with support on the back, and also food should be attractive. Also, we have to train relatives and caregivers, because they are daily with them 24 hours. They should have information what should be the atmosphere in the room. They should understand how we have to perform the elements of physical exercise, massage after stroke. It is very important to assess roughly, but still to assess physical and psychological condition of the patient, and maybe in the dynamic to report the doctor if you see particular changes or worsening, as it was done by this patient's daughter. And definitely this is prevention of complications related to the bedridden patient. Definitely, not only patients, but relatives and caregivers, when they care about such elderly patients, disabled patients, we should assess physiological, psychological situation, voting function. And when you provide this care, massage, movement or rotation of the patient in bed, because the patient is quite contact, definitely, we have to perform all these procedures. And our neurologist is paid attention to a very high importance of caring oral care. This is spilting of oral cavity, cleaning of tongue, and simply examination of tongue. So, in fact, it appeared to be that everything is very simple. The reason of anorexia was that in the mouth, because of increased dryness, this is what we talk about, that was just stomatitis next to the prosthesis. So, simple hygienic procedures, local treatment, temporary removal of the prosthesis, patient go back to normal life, and this problem of recurrent oral ulceration, or so-called after stomatitis was resolved. In pandemia, we have to recollect that there are methodological guidelines for the remote care of the patients, and specifically patients with strokes. What do we have to pay attention to? First of all, blood pressure control, and it is regularly done. We need to avoid excessive reduction of blood pressure. We have to stimulate patients to the verticalization, to the activization. We have to train caregivers, and if infection is in the family, so when you administer antiviral or antibacterial treatments, we need to understand what could be potential drug-drug interaction with the standard treatment of the patient, which is patient taking routinely. And definitely, it's better provide a remote control for such patients, which is allowed by the order of the Ministry of Health about the telemedical technologies. But still open questions which need to be clarified. How to prevent falls in the elderly patients, and we do hope that patients will be able to mobilize. How can we prevent osteoporosis and fractures? What do we have to pay attention to when we administer medical treatment to a very elderly patients? And what is the tactics and painkilling in elderly population? So, and these questions we would like to ask to our next speakers who are with us today. Dear Olga, thank you very much for your case. Very informative case, and I think we are all witnessing the real case, the real story. When comorbid patient with such complex somatic pathology, with fractures, post-stroke status, the one who really needs very personalized approach, and this patient received a very clear diagnosis and will finally get adequate treatment and rehabilitation. And truly, we can appreciate the example of how important is to collect the medical history, then to have proper examination, and then to find solutions, simple solution for complex tasks, like in your case of aphthous stomatitis. Distinguished colleagues, let us proceed our symposium. And there is another interesting presentation that would be made by Anna Turusheva, who is Associate Professor of Northwest University Family Medicine Chair. And she will present on the falls in elderly as the complex problem requiring the attention of a family doctor. The floor is yours. You're welcome. Good afternoon, distinguished colleagues. Vladimir, thank you very much for giving me the mic. As we said before, Olga initiated a very interesting topic on the multidisciplinary management of elderly patients. And in my presentation, I would like specifically focus on falls. The first thing we discuss is falls. What do we mean by falls for geriatric patients? Fall, it's an episode when suddenly the person is on the floor or on the other surface. We have to say that falls in the geriatric medicine is not including the situation which can happen as a result of unconsciousness, because of syncope, because of epilepsy seizure, or if there is a hit. So these are all situations which are quite benign, not related to these pathologies. The point is that the reason of falls in elderly patients are multiple. And besides, the falls themselves definitely lead to the disorder of the functional status, to development of other progressive geriatric syndromes. That is why falls in geriatry are considered to be as complex, challenging issue. And the confirmation of that is here. In the International Disease Classification, number 10, the coding has number 19, from 1 to 19, depending on the factors that are creating. And besides, in the International Disease Classification, we have specific segment which is called prone to fall, not classified in other segments. This is R29.6, where we don't know for sure when there were no falls, but we know that the person has high risk of falls. The same factors are important for the elderly age. What are these factors? It could be internal or predisposing factors and also external factors related to the environment. According to the data of the study, which was published back in 2002, 30% of falls in elderly patients related to the emergencies or with some external factors. What are the external factors? So this is not smooth surface, this is a stony road that can be seen in multiple cities. This is poor lighting, or factors even at home that may lead to falls. For example, carpets or sleeping surfaces or wires. All that should be taken into consideration when we analyze possible reasons of falls. After the analysis, it was shown that 17% of falls are related to the disbalance or gait dysfunction, and in 13% of cases, these are dizziness. Now let's analyze the factors that create falls in elderly. What factors can create falls in elderly? We should always take into consideration several factors. First, previous falls, because we know that if person fell just once, so there is already higher risk of falls in the future. If there is disbalance, or if there is a reduction of muscle power, muscle strength, or visual acuity disorder, and also we have always taken into consideration the multiple drugs are taken by the elderly. One of the serious factors leading to the increased risk of falls is the reduction of pace of walking pace. In average, the walking pace reduced by 12 to 16% every 10 years after 60 years. And the low pace, which is considered less than 0.6 meters per second, or gait disorder, is the important risk factor of falls in the elderly age that leads to the immobilization, hospitalization, and higher risk of mortality. At the same time, high pace of walking, which is higher than 1 meter per second, is actually the factor which reduces the risks of falls in the elderly age. So how do we assess the pace? So we can do two tests. It's either 6-minute walking test or up and go test. For up and go test, more than 14 seconds means that patient is in the high risk of falls. So when we perform up and go tests, we always have to pay attention not simply to the pace, but to the gait. So how the person is moving, whether it's stable gait or not, whether it needs help or not, any changes of gait. Let's say a very small pace, very small, or scraping steps, because all these disorders can increase risk of falls. It's important to pay attention other comorbidities like reduction of cognitive function. So is 3 times higher risk of falls in patients without cognitive dysfunction. So cognitive dysfunction versus the picture. But the reduction of pace is a risk factor for the cognitive impairment in elderly age. So what is the prevalence of falls in elderly age? Surely, a priori, we believe that risk of falls in elderly age is much higher than in younger or in the middle age. In our center, back in 2017, we carried out a study where we recruited 262 patients aged 65 plus. The main objective of the study was to analyze what is the prevalence of factors among the elderly patients that can increase risks. And according to the results, we found out that 40% of the patients do have reduction of visual acuity, reduced hearing loss, and also urine incontinence. Also, we identify high prevalence of cognitive function, low level of physical activity, and disbalance. Studies, we saw very high risk of falls, and for that we had sampling of the patients. That means that really elderly patients have high risks of falls. So these are social levels. They have higher risks of falls than in general population. According to the data of the study, about 50% of these elderly patients, they have minimum 1 fall a year. And more than 50% fall more than once a year. You have to pay attention to that. Falls definitely lead to the reduced quality of life. In 50% of the cases, patients losing self-care after the fall, which is 20% higher, increases the mortality risks, especially at the age of 85 plus. And also, very many falls, in 20 to 30% of the cases, they lead to the traumas, fractures, and brain injuries. In order to assess how prevalent are false among St. Petersburg population. We carried out a study back in 2019 in one of the outpatients on Vyborgsky region of the city. We recruited 105 patients there aged from 60 to 93 years old. And by the results of the study, we identified 34% of participants that were falling at least once for the last 12 months, and 42% of the participants had fractures in the medical history. So when we analyzed the consequences of the falls, we found out that 69% of the participants of the study, they did not have any consequences after the falls. 25% of those who fell and got traumas, different traumas from bruises up to the fractures. In 3%, falls led to the loss of the motor activity. And finally, they were dependent from the third party. And in 3%, falls led to the fatal outcomes. And if we analyze this picture, so on the one hand, we can see that in 69% of the cases, falls did not lead to particular traumas. But we do remember that even those falls that did not lead to traumas, they increase risk of falls in the future, and correspondingly, they increase risk of traumas related to the future falls. So we have to talk to our patients about the prevention of falls. And here we have to do it dual way. First, we have to reduce individual risks. That means we need to design individual programs to reduce the risk of falls. And also carry out population trials for the reduction of risk of falls in the elderly age. How we can do it? Yes, surely we need to identify the patients that are in the risk group for falls. And we need to identify factors that can lead to that. And the most important, we need to identify potentially modifiable risk factors and then to reduce risks of falls in our elderly patients. So how can we do it? By Russian Gerontological Scientific Center, we offered to all the patients who are coming to the visit to the GPs or to the general practitioners, we ask them to provide questionnaires to the patients. And while the patient is expecting the appointment, they can fill in these documents. So here you see that there are confirmations that allow to identify the person who is in the risk group of falls, and there are proper explanations how these factors can be related to falls specifically. For example, I fell last year, and correspondingly, why is this important? Because people who fell once would definitely fall once again. Yes, I am supported by the furniture when I'm walking. That means the person has got disbalance, or it's difficult for me to move up or to stand up from the chair or to step up the ladder. So that means the patient has particular weakness of lower extremities muscles that helps us to work on that. So correspondingly, if upon the results of the questionnaire, we see that the score is 4 or more, so it means 4 or more positive answers. So these patients belong to the high risk group, and here we have to provide deeper or extended assessments. So if we cannot provide these questionnaires, so we can ask 3 main key questions here. Did you have, during last 6 months, any traumas related to falls or falls without traumas? Do you see any unsureness when you move or work, and whether you are afraid of falls or not? Because it has been shown that even those who are afraid of falls, they have higher risk of falls than those who fell before. So positive answer to any of these questions is telling us that the patient is in the risk group of falls. And finally, Russian Gerontological Research Clinical Center offered a particular approach. If the patient is answering positively at least one of these 3 questions mentioned above, then further on, we can make up-and-go test. If test takes more than 14 seconds, that means the patient is in the high-risk group of falls. If less than 14 seconds or gave all negative questions to particular questions, so it has lower risks of falls. But sooner or later, we still need to provide additional assessment and to provide a recommendation for the prevention of falls. When we identify a risk of falls, we should give recommendation for the neurological assessment, rheumatological assessment, and orthopedic surgeons. We should provide additional assessment of the heart rate, blood pressure, to provide orthostatic samplings and also cognitive function assessments. Also, we need to provide the assessments of treatments which is taken by the patients, drug-drug interaction, and the highest risk to bring to falls are antidepressants, anxiolytics, neuroleptics, and antihypertensive treatments. When we make the assessment, we have to give recommendations on the prevention of falls. The most effective here are schools for the prevention of falls, patient schools that can be carried out in the medical centers. We have to give recommendations on the improved physical activity, correct shoes, good selection of shoes, then organization of the household around, correction of the medical treatment. And according to the data of the study, the most resultatives were the following activities. First of all, limitation of number of drugs, physical exercise, and household organization, household space. So more detailed organization of how it can be organized for the patients, you can meet these links. These are links for the Gerontology Research Center or MedPoint website or in the All-Russian Spring Geriatry School. Thank you very much for your attention. Well, thank you very much, Anna. Yes, that was very interesting presentation because this is really significant and very challenging issue in the life of the elderly patient. And I believe that we're not just understanding the relevance, the importance of the issue, but also Anna gave us particular tools of how we can make objective measurements and how we can provide best approaches to our patients, systemic approaches. And I think this is very logical that after the topic of falls in elderly patients, we are expecting the continuation, the topic of osteoporosis from epidemiology to treatment. And this presentation will be made by a very famous specialist in osteoporosis, Olga Lesnyak, who is a professor and doctor of medical science, a professor of family medicine chair, Northwest State Medical University, named after Mechnikov. Olga, the floor is yours. Microphone, microphone. Distinguished colleagues, distinguished colleagues, distinguished colleagues, I am not muted anymore. So there are some challenges with sound in the platform. So, but once again, let me repeat it. The topic which was mentioned before, this presentation will be made by one of the leading specialists in the diagnosis and treatment of osteoporosis, Olga Lesnyak. So this topic is very relevant. One of the key ones for the management of the disease in elderly patients. And we all know how dramatic could be the end of falls because of the reduction of bone mineral density, patients with osteoporosis with verified manifest osteoporosis. And I think that the technical challenge would be resolved in a few seconds. Can you hear me now? And in this symposium, we are also discussing the issues of drug-drug interaction for the treatment of elderly patients, and I believe this is also extremely important. And I would say it's a strategic issue because our comorbid patients require prevention of falls, they require proper treatment of osteoporosis, and also they need to be cared by multidisciplinary teams, and each proper disease should have proper treatments. So merged together as a multidisciplinary team, we can easily guide and identify most appropriate schemes of treatment, because sometimes when there are multiple treatments, we don't always understand these drug-drug interactions, where they can weaken us, or if they have additive properties. There are different therapeutic approaches. And besides, we also go back to the topic of pain syndrome in the elderly patients. And this is also one of very important issues that is associated with elderly age of our patients. And let's discuss it in this symposium, very important. And I believe that one of the most important issues today for us and I do hope that very different presentations, clinical presentations, and discussion of other issues and this symposium is completely fulfilled. Okay, finally, I think we managed to improve connection with Olga. So, Olga, the floor is yours. Thank you very much. I can continue this case from the point of osteoporosis. I remind you that we are discussing a patient of 90 years old who had femoral fracture. And what we are clarifying today, and I'm taking two questions. First of all, is there any option to prevent osteoporosis development and to prevent further fractures in our patients? And what we have to pay attention to when we administer medical treatment for geriatric practice from the point of osteoporosis treatments. So, osteoporosis, fragile bones. These are bones that can be cracked with minimal trauma, and our 90-year-old patient that we're discussing today demonstrated us very clearly this type of fracture. This is a proximal femoral fracture, which happens with minimal trauma. In fact, the fractures in elderly patients, fractures in the geriatric practice are very prevalent. If you take all possible ages, starting from the age of 50 plus, all people, so 1 of 3 females and 1 of 5 males in the rest life expectancy, at least once would have bone fractures because of osteoporosis. And in females, the risk of the proximal femoral fracture is higher than the risk of 3 cancers: breast cancer, ovarian cancer, and uterus cancer. And in males, the risk of only this type of fracture, proximal femoral fracture, increases the risk of prostate cancer. It's higher than the risk of the prostate cancer. So when we talk about the proximal femoral fracture, we have to understand that this is one of the leading clinical syndromes of osteoporosis, one of the leading manifestations. So for the doctor of the primary chain, it's very important to understand when the patient has this type of fracture, this is clear clinical manifestation of osteoporosis and the confirmation by densitometry of this situation. It does not require any confirmation. Like in our case, the femoral fracture very frequently develops in patients after the stroke as a result of long-term immobilization. And normally, this is not proper rehabilitation when the patient started moving and when the patient had high risks of falls. Although we have to admit that this type of fracture may happen even in bed when the patient simply rotating in bed in the lying position. These are so-called low-energy fractures. First thing, when we talk, why do we need to treat this patient? Because fractures are always here. About 10% of these patients, they have totally opposite manifestation, and it happens for the first 2 years. And there are future fractures which are possible, and we need to do something with this situation. Osteoporosis treatment focuses on the prevention of fractures, specifically low-energy fractures or low-impact fractures. We need to prevent future fractures, but I believe that femoral fracture will lead to immobilization of the patients because the neck is supplied only through the neck, and then the patient will not be able to restore, to recover simultaneously. If it's just trochanteric fracture, then we can hope for the recovery. But the patients with the proximal femoral fractures, in order to recover the function, they need surgery and only surgery. And it is done because of life indications. But nevertheless, our patient was not referred to the surgery, but because of the fact that the patient is immobilized and osteoporosis will be progressing, immobilization osteoporosis, and in order to prevent secondary fractures, we need to start treating osteoporosis. And main group of drugs in this case are bisphosphonates. We can use bisphosphonates peros, and we can use parenteral bisphosphonates, but in the immobilized patients, you can consider only parenteral bisphosphonates. Why? Because for the administration of bisphosphonates peros, we need to keep position for 40 minutes after the administration of the tablet, vertical position, to avoid complications from the esophagus. These patients definitely will not be able to keep up 40 minutes verticalization. That's why here it's just parenteral bisphosphonates and nothing else. So we have two parenteral bisphosphonates. This is ibandronet, which is once in 3 months. But male osteoporosis is not indicated. That's why formally we cannot administer our patient ibandronet 3 milligrams intravenous. It's only zoledronic acid, 5 milligram intravenously once a year. So this is infusion just once a year, zoledronic acid infusion. And such treatment can be provided only once a year. And in fact, this is really very convenient. Let me remind you that zoledronic acid reduces the risks of all localizations for the fracture. So there was a study for 3 years. So zoledronic acid was reduced 3 times consecutively, once each year. 3 years later, they reduced femoral fractures by 40%, they reduced spine fractures by 70%, and by 25, they reduced the risk of extravertebral fractures, and this is really very effective treatment, zoledronic acid. And what is very important to know about zoledronic acid is that zoledronic acid, after 3 consecutive infusions, reduces the risk of all-cause mortality after the femoral fracture, and the risk is reduced by 28%. So this study actually proved that the patients after the proximal femoral fracture, they started injecting zoledronic acid in those who got it versus those who were in placebo group. So their risk of mortality was reduced by 28%. And I think this is a very significant factor which we have to take into consideration when we see the elderly patients with proximal femoral fracture or any other hip fracture. We really continue and prolong the life expectancy for these patients. Besides the fact that we need to start treating osteoporosis with bisphosphonates, we also need to know very important things on what is associated or what should be concomitant for this treatment. So first, before you start the infusion of zoledronic acid, you need to look at blood tests, and first is calcium. Well, first of all, looking at what Olga told us before, this male has never ever received vitamin D. So I have to tell you from the very beginning that elderly patients aged 65 plus should get vitamin D daily, all year round. This is not just the prevention of fractures, because possibly this is not the most important, but prevention of falls, which is extremely important, very important, prevention by vitamin D. And plus to that, vitamin D deficiency is associated with hypocalcemia. In hypocalcemia, we should never ever reduce bisphosphonates because they're anti-resorptive treatments. They just worsen this hypocalcemia caused by the deficiency of vitamin D. So first we need to do is to check blood. We should check calcium and increase it by vitamin D. And even if the patient has no hypocalcemia, still before the administration we should give the loading dose of vitamin D to restore it, because we have a big suspicion that patient has very deep deficiency of vitamin D. What is also important, when you replenish vitamin D, the patient would have a lower risk of flu-like reaction, which we frequently see at first injection of zoledronic acid. So if before the start of pathogenetic treatment of osteoporosis, the patient was not taking the additives of vitamin D, and we cannot check the blood concentration, and we are planning strong anti-resorptives, specifically zoledronic acid, then we need to administer native vitamin D, D3, in the dose of 5,000 international units, which are 10 drops, within the next 10 days, and then move to the standard dose, and then you can start injection of zoledronic acid. So wrapping up and going back to the case, we need to understand that in elderly patients, the modern pathogenetic treatment of osteoporosis is absolutely safe and very effectively preventing the secondary fractures, reducing the mortality rate in elderly patients. And this treatment should be associated with vitamin D and calcium, because this is very important background treatment of osteoporosis, which is combating the negative effects of bisphosphonates, and the same treatment is preventing falls. Thank you very much for your attention. Thank you very much, Olga. Yes, this is very comprehensive. This is pivotal presentation, very illustrative presentation that covered the challenge of osteoporosis. And now I'm happy to give the floor to our next speaker, Dr. Turusheva. And this is a topic which I already mentioned before. This is drug-drug interactions and polypharmacia in the treatment of elderly patients. The floor is yours. You are welcome. Dear colleagues, thank you very much. Today we will talk about polypragmasia and the importance of correction of it in elderly patients. In elderly patients, the objectives of pharmacological treatment is change. If in younger and middle age, it's mainly reliable and safe control of the disease because of its administered. Definitely, it's important in the elderly age as well. But besides the treatment of main disease, what is very important for the elderly patients, there are two important objectives. First is to support and improve functional status of the patients. That means preservation of physical and cognitive function, which is needed for the long-term independence. Besides, another objective should be here. It's a prevention of progression of already existing geriatric syndromes and appearance of new geriatric syndromes. What is happening with age? With age, we normally see the increased risks of adverse reactions related to possible overdosing of drugs and also drug-drug interactions. First, we observe some age-related changes in pharmacokinetics and pharmacodynamics. Plus to that, in elderly patients, the increased prevalence of cognitive dysfunction, increased risks of orthostatic hypertension, increased risks of falls. And in elderly patients, we see several diseases simultaneously, and it requires administration of more and more drugs that leads to polypharmacy. And as a result, polypharmacy in elderly patients is considered to be a separate geriatric syndrome. According to the literature data, we already know that polypharmacy is a very frequent situation that leads to multiple unfavorable effects. That is why, at our chair, we decided to carry out a short study to identify what is the situation in our Center of Family Medicine. And in 2015, the students of our Young Students Scientific Society carried out a short study where we recruited 50 patients. They were absolutely randomly selected, and that emphasizes the value of this study. Those patients were aged 65 plus. The analysis of drugs was carried out using structured questionnaire. According to the results of the study, the most prevalent diseases, like expected, were hypertensive, ischemic heart disease, and degenerative diseases of the spine. And in 50% of those who we recruited, we saw polypharmacy. So what are the specificities of polypharmacy we observed? Well, the biggest number of drugs was 15 drugs daily. Can you imagine? Totally 23% of those who had 15 drugs, they actually self-administered them. We found out that there is a big prevalence of drugs that are taken by elderly, and they don't believe that these are drugs. They don't know that these are drugs. For example, anti-inflammatory, vitamins, and different biologically active additives. And unfortunately, patients very frequently do not report to their doctors that they administer something else. And in 95% of the cases, we saw that the treatment was not corrected, was not adjusted. That means there were no more indications, but the drug was still used. Most frequently, it was typical for proton pump inhibitors, PPIs. What is the main reason of polypharmacy that can be identified as a result of this study? In majority of the cases, in the treatment of the elderly patients, we look at these patients not in complex, but like a combination of different diseases and syndromes, and we try to treat each syndrome separately. The other thing is fragmented help, because very frequently patients they're treated not just by one family doctors or just GPs, but patients get consultations additionally from specialists, from cardiologists, from rheumatologists, and they also administer some treatments, and very frequently they don't take into consideration drugs administered earlier. Besides, in elderly patients, we have several diseases, and we should always make a decision what disease to treat here and now, or maybe we have to treat all of them, or maybe which disease is playing the bigger role, is dominating in the condition of this elderly patient. And also very frequently, we have repetition of administration. For example, patient is taking some drug, but is taking something else because of the exacerbation of the disease. For example, patients with arterial hypertension start taking non-steroid anti-inflammatory treatments because of pain, back pain, and that reduces the efficacy of antihypertensive treatment and correspondingly increases the risks. And also, a very important aspect that we should always pay attention to is alternative medicine. As I told you before, very frequently elderly patients, they don't believe that herbals, drugs or biological additives, they don't consider them to be drugs. And the using of herbal treatments and phyto treatments and vitamins and biological additives in elderly is 3 times higher than in younger patients. We should always remember and explain patients that those herbs and biological additives, they also give adverse events, adverse reactions. They could contain impurities. They could lead to drug interactions in between the standard pharmacological medicine. So that's why we should always ask this question in our patients. What doctors themselves think about polypharmacy, about its reasons by the result of the study? Very frequently, the problem of polypharmacy related to the fact that new symptoms in elderly patients sometimes are difficult to identify. You never know whether it's progression of main disease or maybe it is development of a side effect. from the treatment that has already been administered. As I told you before, we need to understand what patient is taking in reality and how he's taking the treatment. So sometimes additional doses or new doses are administered when we believe that they're not effective. But the main reason may be explained by the fact that patient simply skips the doses because of the cognitive dysfunction. And an important thing I would like to draw your attention to is the importance of the guidelines. Because the doctors, they're trying to disease one specific disease. They're following guidelines and they are overdose. They're over-treating patients, administering them too many treatments. But also there are patient factors that also lead to polypharmacy. Well, first of all, these are patients who frequently are afraid to refuse from all drugs like benzodiazepine or others, corvalol. Many drugs are not considered to be drugs for them. They don't believe that there could be any adverse reaction here. And they're quite not compliant to the recommendation of the doctors. And very frequently at the end, when we first speak about the need to change the lifestyle, for example, in case of loss of sleep, we always speak about the increased physical activity, some hygiene of sleep. Well, it's always more difficult to do than to take a tablet. Tablet is always easier. So patients are expecting, oh, I have a symptom, then I need to get a tablet. And this is one of additional factors that leads also to the polypharmacy. According to the data of the study, polypharmacy causes higher rate of adverse events that we see in overtreating of the patients. And what is important here, sometimes adverse events that are seen after the administration of particular drugs, they happen after the administration with pretty long administration. After the start of administration. So when patients have some new symptoms, they never know whether it's related to progression of the disease or maybe it's adverse event of the treatment. And very frequently, they simply don't refer to doctors with this issue. What are the consequences of polypharmacy in general practice? First of all, this is the increased risk of falls or disbalance. Besides, very frequently, polypharmacy leads to the reduction of cognitive function. And the more drugs we administer, the worse compliant are the patients to our recommendations. And patients themselves are missed. They're confused. What should be taken? What time? So correspondingly, it all leads to the cascade of administrations and recommendations. So we administer something, then there is no effect, we adjust new symptoms, then we adjust, and then the number of drugs is simply increasing and increasing. Inevitably, it leads to the increased risk of hospitalization and increased costs. So how can we fight polypharmacy? So by now, there are several tools available, and one of them is the algorithm of 7 steps. 7 steps algorithm. So we can identify first what sort of drugs patient is taking, what are of them important for the life indications, then to set targets and to adjust the treatment. The other criteria is so-called BEER criteria, start and stop criteria, so multiple criteria that you can find on the links shown here. BEER's criteria were designed to support decision-making when you administer drug treatment to the patient 65 plus in the outpatient scenario. So all the drugs split into 3 categories. Drugs that are not favorable for the elderly, those that are dangerous, and also potential in dangerous drug-drug interaction, or the drugs that are not indicated in specific diseases and syndromes. And you can find all of them there. So the doctor can always refer to this criteria in decision-making about the administration or discontinuation of particular drug. The other criteria that can be also very useful in general practice, this is criteria stop and start. These criteria were designed for the screening of potentially non-rational administration of drugs, non-rational, not justified. But on the other hand, we can use the same criteria, specifically start criteria, to identify the situation where the administration of new drug is justified, is needed. And last update guidelines dated 2019, so you can find them following this link. By now, we published clinical guidelines on the pharmacotherapy in patients of elderly and frail age. So they are open, available, and you can download them by this link shown here at the bottom of the slide. And wrapping up, I would like to say a few words about de-escalation of treatment, so-called de-prescribing. So we stop the administration of something. So we always should analyze why this or that drug is administered and is the continuation of the administration is justified or not. So we need to think what drug can be stopped in order to minimize the number of treatments. So here it's important to remember that all discontinuations should be properly justified and should not be harmful for the patients. Although we are saying that the drug should be discontinued, but in fact, discontinue the drug, really, we can do only in 81% of the cases. So how to select what to discontinue? First, start discontinuation with the treatments that could lead to the lowest risk of the rebound syndrome. Then discontinue the ones which are unclear or there are no indications for these treatments. On the next stage, you can discontinue if the patient is having indications but with minimal benefit, bringing minimal benefit. And please discontinue the ones if there is a benefit, but the risks are much higher than the benefits. So what strategies can be used here? First of all, to assess the number of tablets taken by the patients, use screening criteria, always think about the discontinuation, administer them strategically. It simplifies the regimen, use the combinations, or use the drugs that have multi-action mode of action. In order to control drug-drug interaction and to avoid unfavorable drug-drug interactions, you can refer to the electronic software or websites that assesses the risks of unfavorable effects. So here there is special section of drug-drug interaction on the website pharmacy.ru or ilsnet.ru. So wrapping up, what I would like to say here, the reduction of pharmacological burden helps us to reduce the rate of adverse events like false hospitalizations among elderly patients, to reduce the number of tablets, to increase compliance of patients to the rest of the drugs, and then to improve quality and to improve quality of life of the patients. An important thing which also we should pay attention to. So when we talk about the correction of treatment or about the discontinuation, here all team members should participate. Should be doctor understanding the targets and medical nurses working with him and also relatives of the patients. Because we always need to control every step ahead, and then the treatment of the patients would be safe enough. Thank you very much for your attention. Thank you very much, Anna. Yes, truly, this is a very interesting topic of polypharmacy. This is our treatment, especially in the treatment of elderly and very elderly patients. And we continue our symposium, which I remind you is carried out in the hall of St. Petersburg in our online Congress of Internal Medicine of the Eurasian Association of the Therapists. And we continue with the presentation of the Family Medicine Chair Lead, Dr. Kuznetsova, who will speak on the specificity of pain syndrome treatment in the elderly or frail patients. The floor is yours. You're welcome. Distinguished colleagues, my welcome again. And today I would like to share, while the technical preparation is ongoing, we have one question to ask, and hopefully we can discuss it now. So there is a question to Dr. Turusheva about your last presentation. Are you with us, Anna? Yes, I'm here. I'm ready to answer the question. Okay, very good. Anna, We received a question from a doctor from Pskov. Could you tell us what charts of drug-drug interaction you are using, and do you think whether this approach is justified to check possible drug-drug interaction through this chart? Well, this is exactly what I showed in my presentation. These are charts that we are using in the clinical practice. I can show it once again at the end. When I administer new treatments, if there are some new treatments that I'm not administering before, I'm always checking possible drug-drug interactions and adverse events typical for these treatments in order to be on a safe side and to reduce the risks of unfavorable events in elderly patients. So the other words, those internet resources you mentioned in your presentation, this is exactly what you use. Yes, it will help you to have proper preparation before the start of new treatments. And now we are again happy to give back the floor to Dr. Kuznetsova with the presentation we already announced. Pain in elderly. Distinguished colleagues, I hope you can hear me. Yes, positive. And you can see the presentation. Yes, we can. Thank you very much. Distinguished colleagues, I would like to draw your attention to a very important issue for the treatment of pain syndrome in elderly patients. Yes, now it's okay. Thank you very much. So, distinguished colleagues, the treatment of the pain syndrome is extremely important. This is a relevant challenge because we already spoke about our patient who could have this pain syndrome. Please appreciate how frequently we see pain syndrome in the elderly and very elderly patients. And especially, it is very difficult to manage these issues in elderly patients because we see multiple dysfunctions from absorption points, from the albumin plasma configuration change, which sometimes leads to the long-term effects from the standard doses, then reduction of the renal flow, and it could be some increased fat, reduced muscle tissue, reduced fluids, and also from the nervous system, from CNS, we see changes of the circulation. So this is anti-nociceptive protection reduction, then muscle mass reduction, function reduction, and then increased risk of falls. So what do we have to pay attention to? And again, let me draw your attention to the clinical guidelines on the chronic pain in the patients of the elderly and very elderly age, which was presented by our geriatricians. So yes, there are multiple elderly patients. They have multiple reasons for the pain syndrome. So here it's radiculopathies, then it could be connective tissue disease, osteoarthrosis. So these are infectious diseases and other pathologies in comorbid patients that are frequently seen. But before to treat, we need to measure. What is the specificity of checking of patients with pain syndrome? Yes, we have to collect the medical history very precisely, then localization, then intensity. So something that causes the changes, how it influences mood and sleep, because mood and sleep go hand in hand with depression. Also, in such patients, we need to understand what are the cognitive dysfunction and whether we can use different scales, whether they're applied, to what extent pain syndrome ruins their daily activities. And this is exactly what Anna said before in her presentation, drug-drug interactions. The most frequent localization of pain in elderly, definitely joint pain, muscle pain, in the neck, in the head, plus neuropathic pains of different localization. So when we assess such patients, we need to be very attentive and consider multiple issues in the collection of the medical history. Because it could be the case that the patients believe that it's just elderly age. It's just elderly age, so the pain is typical symptom of aging. But in fact, it's totally wrong. We have to help our patients with pain. We have to use different skills. So this is a VAS, which is very illustrative. This is also a complex scale that helps us to understand to what extent the functioning is ruined, because here we see that this scale first was pediatric, but now it can easily be applied to the patients with cognitive disorders. And plus to that, if we deal with the patient that had a strong dementia, then we can also use this complex assessment, the scale that according to particular physiological scales, can help us to assess whether the patient is suffering from pain. Let's say when we look at breathing, localization, so the mood or maybe the face mask, and also mobility and how the patient is reacting to the stimulus. So what are the barriers in painkilling in elderly? Why are we talking about this challenge? Because unfortunately, as we said before, there are some physiological changes, sensory cognitive changes, polypharmacy, when each specialist is administering something. And as we said before, we have comorbidities here. Pain syndrome treatment. This is not just the symptoms. This is the complex program of managing such patients. This is availability or severity of comorbidities. This is the planning of the multimodal approach, which includes both medical and non-medical corrections and treatment, possible rehabilitation. Then the critical alliance with the patient, with his or her relatives, like in our case, to make them understand what can they use as an important part of care if pain is developing and there is no doctor next to it. Then the analysis of pain killing that is already available currently, and also the analysis of resources and possible social care that can be used in order to improve the treatment of the pain syndrome, chronic pain. So, non-pharmacological methods of treatment. First of all, it's a training of patient. Patient should understand why is the pain, what is the reason of pain. Patient should know how to use physical exercise, how to modify the lifestyle, and the relatives should help with that. So the patient should understand what self-care methods are available. Very simple things. As a treatment of the first line, here we can use it. So it can be both cold and heat. It could be physical exercise and complex exercises. When we select treatment, this is pain killing by hour, then Peros, and then approaching ladder. And also in the treatment, it depends on the intensity of pain, adverse events, and the best available is definitely NSAIDs, non-steroid anti-inflammatory treatments, and in high pain intensity, it could be opioid analgesics, tramadol, and also currently in the joint pain, we use symptomatic low-release drugs. Speaking about NSAIDs, well, first line is paracetamol or acetaminophen, which already proved its efficacy and safety. Yes, it cannot be used in case of liver diseases, and you should not overuse it. We should have clear understanding in what situation paracetamol can be used. But definitely, it's very good first-line treatment, non-selective NSAIDs. So they should be used with caution, because we have to protect the gastric mucosa, because actually for the elderly and frail patients, we see multiple complications. And then two drugs immediately completely excluded, but because then we have exponential increased risks. NSAIDs are not recommended. So here there are clear, stringent recommendations not to administer NSAIDs, and these are guidelines of geriatricians. In case of frail asthenia after cardiovascular events, cerebrovascular events, after the vascular interventions, and if CKD is low enough. What is interesting, so this is very new information in clinical guidelines about the importance of using of vitamin D. Olga already spoke about it. So for patients with chronic pain, yes, here we also need to check the level of vitamin D to avoid deficiency because, as it has already been proved in the multiple studies, in case of low level of vitamin D, we will have challenges with pain killing. So pain killing would not be as effective as it should be. So in case of vitamin D deficiency, we should definitely administer this drug daily, and then for the maintenance treatment in order to support the level from 1,000 to 2,000 units daily. The complex vitamin B approaches are not yet designed, so normally it's used for the myelinization of the fibers, but yet there are not multiple studies, so the final decision about the administration of this type of treatments should be approved by the patient, and if it's agreed that they can administer it. Besides, if we face oncological pathology, and then for the resolution of the pain syndrome, we should use narcotic analgesics, and here we need a consultation of palliative specialists because this is rather challenging for oncology patients. So this is the ladder of decision making. This is how we are analyzing the status of the patient and we are getting the assessment of pain. Definitely, opioid analgesics are indicated, but this is again timely manner. If the patient had burning pain, that means neuropathy, that means today in the clinical guidelines, they're offering this type of treatment. So first line is antidepressants or anticonvulsants. The second line, combination of antidepressants with anticonvulsants. And the third line of treatment, tramadol, or the first line in a bigger dose. Speaking about antidepressants, we have to say that amitriptyline is excluded in elderly patients, not just to cardiovascular diseases, but worsening of the cognitive function. That's why mainly we administer duloxetine, which is quite modern inhibitor of reverse serotonin intake. Anticonvulsives, so gabapentin, starting dose 100 milligram per night, pregabalin also effective, but sometimes there could be sedative effects, peripheral edemas, and we have to monitor renal function. So distinguished colleagues, wrapping up, pain is not, we are normally see it at age, but we shouldn't. Definitely, pain is complicated by problems in elderly age, and in the selection of adequate pain-killing treatment, we have to assess not only the severity of pain, but also the influence of pain to the daily activities of elderly patients. And always remember about complications. And I would like to thank our team. I think they demonstrated the importance of this multidisciplinary approach and the efficacy of this approach, caring about elderly patients. Thank you very much. Thank you very much, Dr. Kuznetsova. And many thanks to all the experts who participated in this symposium, and I'm pretty sure the audience will agree with me. This is very practical and highly demanded symposium because we have more and more patients like this, and this is the value of that information. This is very high value. So we have about 2 minutes before the end, so we have time for 2 questions to ask. There are multiple questions here, so let me select 2 of them. Irina from Donetsk. The question to Olga Lesnyak. If the diagnosis of osteoporosis is already made, what level of physical activity is needed? If there is diagnosis of osteoporosis, physical activity is extremely important. It should be at least 30 minutes daily, at least 5 times a week. But in this case, we need to limit dangerous movements that could facilitate fractures. This is running fast, twists. The other words, there should be safe physical exercise. So we sometimes recommend patients to have several sessions with the coach to select proper program. Thank you very much, Olga. Thank you very much. And another question from the doctor from Moscow. So today it's a very relevant topic of sarcopenia for patients 65 plus. Any early diagnostic tools? Can we slow down the progress of sarcopenia? Possibly this question is to Dr. Kuznetsova, because we discussed falls and we discussed issues of sarcopenia. Well, this is very complex, although very interesting issue. Early features of sarcopenia, in order to prove that this is sarcopenia, they don't exist. What we normally say that this is a loss of muscle mass that we are assessing for the last 3-5 months that may tell us about the loss of muscle mass. Second indirect approach that helps us to assess is the strength of muscle, and this is dynamometry that also recommended to our patients. And also we have to assess whether there is any reduction of muscle strength, and if yes, then we can suspect sarcopenia and possible loss of muscle mass. Also, another method that can be very useful here, and the simplest one, is to measure the thickness of prick in the muscle, and they count the muscle volume in the shoulder. So how do we prevent the loss of muscle mass age-related? Just physical exercise. Just physical exercise. This is according to the clinical guidelines, according to the trials. So this is the increased level of the physical activity, and this is full-fledged nutrition. So we recommend our patients with sarcopenia to increase the protein uptake up to 1.5 grams per day. And the most important is not just the increase of the protein, but this should be regular increased doses of proteins. This is how we can combat sarcopenia. Thank you very much, distinguished colleagues. I think I can confirm unified position that really we enjoyed this symposium, very interesting and very modern presentation. So with that, we would like to close this session of our online Congress of Internal Diseases. And before the break, and let's check the watch. So we deserve 15-minute break. So we meet again, we reconvene at 3:30 p.m. Moscow time, and that would be innovative technologies in the diagnosis and treatment of rheumatology diseases. So meet here after break, St. Petersburg, 3:30 p.m. Moscow time. Please enjoy your break. Thank you very much.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
позвольте номинировать следующий симпозиум. Напомню, что мы с вами участвуем в работе онлайн-конгресса внутренних болезней, 10-й международной конференции Евразийской ассоциации терапевтов. И эта часть, этот сегмент конгресса проходит в Санкт-Петербурге, и отсюда из Санкт-Петербурга транслируется. И я хочу с большим удовольствием номинировать тот симпозиум, который состоится сейчас, которому вы будете свидетелями. Это симпозиум, который называется «Инновационные технологии в диагностике и лечении ревматических заболеваний». При этом, уважаемые коллеги, с огромным удовольствием хотел бы предоставить слово и право открыть этот симпозиум Мазурову Вадиму Ивановичу.
So I would like to give the floor to Mazurov Vadim Ivanovich, one of the most prominent therapists and rheumatologists in our country and abroad. He made a great contribution to the development of practical medicine. This is a person of encyclopedic knowledge in internal diseases, and I was surprised to learn that he's only the honorary doctor of the military academy, but also of the Mechnikov Institute, and he is representative of the Mechnikov Institute today. And the subject of his presentation he is going to make is connective tissues disease, mixed connective tissue disease, and overlap syndromes. Well, Vladimir Ivanovich, you are given the floor. Good afternoon, dear colleagues. I would like to say that this symposium, which is devoted to the difficulties of diagnosing rheumatoid diseases, is very interesting. It is one of the most interesting sections of the internal pathology because rheumatoid diseases absorb or involve all organs and all systems that are affected in the case of different immunological diseases. So today I have chosen mixed connective tissue disease and overlap syndromes because this is a very difficult diagnosis when we see some features of some autoimmune disease and features of another autoimmune disease, and how can we define whether these are 2, 3 diseases with separate symptoms, or it is one disease that is called mixed connective tissue disease. Not long ago, in 1972, quite recently, Sharp first described, with his doctors, described and identified it as an independent disease. This is a symptoma complex. First of all, it is a rare systemic disease of the connective tissue that is characterized by the combination of some signs of the systemic lupus erythematosus, systemic scleroderma, rheumatoid arthritis, polymyositis with the antibodies to the dissoluble ribonucleoprotein in high titers. So not only these markers, I will speak about others that are necessary to identify the diagnosis that characterizes this mixed connective tissue disease. The frequency is not very high. It's about 1.9, 3.8 per 100,000 population. Nevertheless, the issues associated with the diagnosis of the disease is difficult, and that leads to the late diagnosis and late treatment. Women are predominant. The ratio of female and males is from 3:1 to 16:1. The disease develops mainly in the age of 28, 48. The peak of incidence is 40 years. We see that in 1986, the first pediatric cases were described. So the prognosis is quite unfavorable because of the lung disorders. First of all, the pulmonary arterial hypertension. Here we can make a parallel interstitial renal disorders and COVID infection that we experience now can be also manifested in serious interstitial lung damages, affections, and leads to the alveolar block that leads to the hypoxia. And you know, systemic scleroderma, that is part of the complex of connective tissue diseases, is one of the diseases that is accompanied by interstitial pneumonias. It can be the ordinary or specific interstitial pneumonia. And finally, fibrosis, that's what is connected with the final outcome. And different overlap syndromes are connected with each other. We understand that lethality is to a great extent connected with the progressing pulmonary failure. The MCTD is a chronic autoimmune disease, and there are different overlapping symptoms such as rheumatoid arthritis and others. And sometimes the issues arise that on the one hand are easy to answer, but on the other, a lot of problems arise. Let us take systemic scleroderma or systemic lupus erythematosus. These diseases have differences, clear differences, but nevertheless, we see with lupus that might be Raynaud syndrome, that is both typical for scleroderma. It is the migrating arthritis, and that can be observed in other systemic autoimmune diseases that may be skin lesions, erythema. We know it, that is accompanied by the mucosal lesions. But first of all, this is the disorder of different organs and systems, renal system, vascular system. On the one hand, we can see very many symptoms that are typical of SKV, but there are also some other, we can see it also in other diseases. It can be SKV and other variants that go with the myositis. So it is all permitted by systemic vasculitis that is very actively goes in case of a lupus erythematosus. As to overlap syndrome, it is a combination of, in one patient, of two or more systemic autoimmune diseases, each of which is corresponding to its own criteria. For example, scleroderma and some signs of arthritis, systemic lupus erythematosus, and some elements of scleroderma. All these manifestations can develop simultaneously or in sequence. They may be they can be found by different immunological measurements or markers. Here I show these antigens where antibodies are developed. The PM is a polymyositis, and SCL is systemic scleroderma. So these markers that we see here are manifested by myositis, by Raynaud syndrome, and by arthritis. As to antibodies, GO1, for example, this is a very frequent situation that we see. These are the so-called variants of antibodies that are shown here, and they lead to myositis. This is a characteristic myositis for this marker, plus arthritis and plus lung lesions. So here we see different variants of antibodies. The first variant and the second variant that is typical, that can be combined with the SCAV and the rheumatoid plus factor that can be an addition. It can be SCCP. If we speak about this variant CCI-CCP, this is Sjögren syndrome that can be combined with the rheumatoid arthritis. All these are overlap syndromes that introduce some difficulties into our diagnosis. A non-differentiated connective tissue disease is characterized by the symptoms of autoimmune disease of the connective tissues, for example, Raynaud phenomenon, arthralgia, and myalgia. But the clinical picture does not correspond to any diagnostic or classification criteria of a definite nosological unit. That's what we should focus on, because overlap syndrome, non-differentiated CTD, and mixed MCTD, they all have their own symptoms. So women develop this disease much more frequently in an good workable age, but the disease may appear in earlier. So the disease may appear from 8 to 80 years of age. So the first thing we can say that this disease has signs of several autoimmune diseases, has certain markers, immunological markers that allow us to make differentiated diagnosis. But what is the etiology and pathogenesis? And here we must say that among many etiological factors, the trigger role is played by viruses. It's not only retroviruses, Epstein-Barr, but many other viruses that can provoke and serve as triggers and launch the autoimmune process. Then also, of course, there may be some various drugs, for example, the group of antibiotics, so the trigger role, which leads to the autoimmune inflammation that can be supported by the genetic predisposition, the association. This is one of the loci that is important, and in case of its activation, some conditions are created that form or provoke the development of autoimmune inflammatory process. Also, we can speak about the pool of erythrocytes formation. I would like to say from the very beginning that most of the macrophages that have toll receptors and they interact with a lot of triggers that launch the disease. This is one of the components that helps transmit the information of antigen-presenting cells to T cells that play an important role in the formation of the inflammatory process. As to the second half is, this is the speak about the pathogenesis, and the basis of the pathogenesis are immunological violations, the result of which is the formation of a large number of antibodies to ribonucleoproteins, circulating immune complexes with development of the moderate hyperglycemia. And of course, the immunological violations are the basis, and these are immuno-inflammatory manifestations. Autoimmune, this word is connected with the formation of monoclonal antibodies or antibodies. They define the face of this or that disease. The result of this interaction and the large number of antibodies to ribonucleoproteins and the formation of immune complexes with the considerable hypercomplementemia. You see that a lot of components are taking part in the process, and they are part of the immune complex. That's why a certain consumption of components is taking place in the immune complex that is deposited in this or that field of the human body, forming local inflammatory processes. Of course, there are serological markers of other rheumatoid diseases, because here we speak about the possible polymonoclonality. That's why we see here different anti-keratin antibodies and others. Thus, in the genesis, a great role is played by the genetically determined violations, disorders that are launched by triggers of the external environment, and that form the pathological process with different antibodies or autoantibodies. As to ribonucleoproteins, so first of all, it's very important, the interaction of these nucleic acids with the proteins. They are formed with the participation of DNA and RNA, ribonucleoproteins or RNP. These are two very important components that play an important role in the diagnosis of these diseases. The typical representatives of RNPP ribosome are ribosomes and informosomes. This is a complex of matrix RNA with proteins. So this is a main pool that is contained in these very informosomes. As to the typical DNA chromatin, this is a complex of DNA with histones and negistone proteins. Nucleoproteins also include different viruses that we have already mentioned, bacteriophages, viruses of plants and animals without any external cover, and nucleocapsids of viruses that contain RNA and DNA with proteins. And they can influence these or those interactions with a large number of receptors, toll receptors that play a very important role in protecting the body from different infections. Now, immunological markers, and that refers to antibodies to RNP that are aimed at the molecule of U1SN RNP, which is one of the main components of spliceosome, which is connected with 3 proteins. It's important to underline it because these 3 proteins play one of the most important roles in identifying and verifying the diagnosis. These are these small histones that are within the kernel, and they interact with the protein substances. Those patients who have mixed diseases, we find these markers are ARRO, anti-SM, and anti-dsDNA. And anti-SM is a very important antigen that plays a very important role in the diagnosis of the systemic lupus erythematosus. And anticardiolipin antibodies that are present in about 15% of patients, rarer than with patients with SKV. So the presence of various autoantibodies served as a predictor of the involvement of various organs or indicated to the existing affection of internal organs. Anti-Rho, this is a component for the nervous system, and the LUGS anti-sclera 70, it's the lesions in the esophagus, ACA associated with the presence of sclerodactylia, anti-dsDNA, IRO, this is serositis. So not only these are the markers that are defined, and with their help, we can solve the problem what clinical manifestations can be observed in this group of patients. Criteria of diagnostics of the MCTD. So that had been described in 1987. This is criteria of MCTD. What are the clinical criteria? Wrist edema, sclerodactylia, with or without proximal scleroderma, Raynaud syndrome, myositis, laboratory or histologically confirmed, and synovitis. And serological criteria that we can define today. So we can define the clinical manifestations with the help of serological criteria. So there are criteria that we can unite today. These are the criteria of 1987 made by Kasukawa. So he identified the serological criterion anti-U1 RNP. But there are general criteria also, Raynaud syndrome and the fingers and wrist edema. These are the main symptoms for SKV, SSDAPM. SKV is polyarthritis, lymphoadenopathy, the rash, serositis, leukopenia or thrombocytopenia. For SSD, sclerodactylia, pulmonary fibrosis, hypermobility or dilatation of the esophagus, which is also very, very important. So for PMs, weak muscles and changes in the electromyography. This is one criteria that I'm showing, allows us to suspect everything that is connected with the whole number of autoimmune scleroderma and systemic lupus erythematosus. So this you see the such pictures very often, and it is not specific for the lupus only. This may be connected with alopecia, it may be connected with the centrifugal erythema, pigmentation, and this is what is connected with the systemic scleroderma. This is the classic variant, and you see this grid on the face. All these signs are typical for scleroderma, for sclerotic lesions. On the one hand, we can see the manifestation of the lupus, and on the other, the scleroderma. These are clinical manifestations that we see here. This is rheumatoid arthritis. This is the affection of joints, varies from minimal arthralgias, arthritis of small and large joints, erosions typical for rheumatoid arthritis, up to mutilating arthritis, which has a very severe course, and it is observed in 60-70% of patients. And to polymyositis, about 40-90% of patients have the muscle involvement. However, there are no specific differences with the muscle syndrome in other diseases of the connective tissue. So it testifies to the fact that there are evidence that there is data. This is a typical deviation here, the figuration of the bone joints. So this is a two-side affection. Also here you see X-ray and see the erosions, the narrowing of the joint slot. So everything that is characteristic of the rheumatoid arthritis. But what is connected with the muscle syndrome? This is the version that combines the figures of RA and polymyositis. So as to the laboratory diagnostics of the disease, it is a very important component, and it shows us the presence of anemic syndrome in these patients. And this anemic syndrome shows not the anemia of iron deficit, but anemia of chronic inflammation. So the ACR is increased in all patients with the active phase of the disease. So we also see the polyclonal hyperglobulinemia, the increased content of circulating immune complexes, and the development of the hypocomplementemia is quite possible. In case of the active myositis, the level of creatine kinase is usually elevated because the muscle fibers are decaying, and it may vary from 10 to 30 times. In case of renal affection, the proteinuria is developed, then micro or microhematuria in the urine test. And finally, we see nephritis or renal failure, and creatinine is urine is raising. Here we see the changes, clinical changes over the 15 years of follow-up. Look what a large number of clinical symptoms we see. First of all, Raynaud syndrome, classical thing already, and for the entire period of the disease for 15 years. So in the debut it was 79, and during the last visit examination it was 60. So syndrome Raynaud is remains with the patient. The same with the arthritis and arthralgia. 68 in the debut, so but it is a bit reduced until the last examination. Hypertonia of the esophagus. So we see that the disease, this syndrome is stable in the course of the disease. It increases from the debut and keeps on the same level. The pulmonary function reduction, wrist edema, myositis, skin rash, sclerodactylia, pleuritis, pericarditis, the nervous system disorders and renal disorders. These are the changes that are typical for the mixed connective tissue disease that can be manifested in different combinations and leads to the progression of the inflammatory lesions of different organs and systems. As to the treatment of this group, we know, and the most important thing here is that suspecting the mixed connective tissue disease is task number 1, and it is connected with the experience of the therapist who sees this patient or follows this patient, this patient, sees the changes that are connected with the SMCTDs. It is quite clear that different markers are difficult to define, but to suspect this clinical picture is very important, and to refer the patient to the rheumatologist. This is the main task faced by the therapist, not so that the patient could give timely therapy of this very difficult group of diseases. So the treatment is based on the recommendations of the treatment of different diseases, for example, lupus, scleroderma, and polymyositis. So inflammatory manifestations, fever, serositis, myositis, arthritis, and skin rash are usually treated by glucocorticoids quite successfully. As to sclerodermic manifestations, sclerodactylia, as a Fagel disorders, Raynaud phenomenon, they require cytostatic immunosuppressive therapy. So we make an accent on the drugs that we know very well and have been using for the treatment of autoimmune diseases. It is cyclophosphamide, cyclosporin, azathioprine, methotrexate, or leflunomide, and one more drug that we use rarely in different autoimmune diseases. It's mofetil, mycophenolate mofetil. So this is the range of immunosuppressants that need to be used in this disease. So there is a number of papers that show that with this disease we can also prescribe inhibitors of the tumor necrosis factor, TNF. Rituximab is most often used. It has an ability to suppress B cells and everything that is associated with the activity of antibodies. So a good, here we see a very good result. Tocilizumab is an inhibitor of interleukin 6, which is used when the joint syndrome is prevailing and when it is more rheumatoid arthritis combined with some other disease. So expressed, and this is an important point that is to be taken into account, the dynamic follow-up over the efficacy of the therapy, because this is a complex therapy. It's not only HANA engineering biological drugs. As to the overlap syndrome, this is syndrome of the state that is characterized by diagnostical criteria of 2 or more diseases of the connective tissue in one patient. And it is not just the summing up of symptoms, but the mutual worsening of one disease over the other. And it is very important in diagnosis to interpret correctly clinical manifestations, laboratory and instrumental data, the data that are received from the antibodies test. Specific serological markers are very important. So the signs of different diseases can be simultaneous or sequential and at different time. So specific serological markers for the overlap syndrome are for scleroderma plus dermatomyositis or polymyositis, which is combined with this markers, anti-PM SCL, then anti-Q, a very characteristic marker for the overlap syndrome. And those markers that are shown here are anti-U2 RNP and anti-U5 RNP antibodies that can be also used for assessing the overlap syndrome. So there might be overlap syndromes of scleroderma, of lupus, rheumatoid arthritis, different Raynaud phenomenon variations with the Sjogren's syndrome, with mixed connective tissue disease, with lupus, or with and finally, mixed connective tissue diseases that can be combined with lupus. Clinical associations of autoantibodies in overlap syndromes. It's again important to look at these nucleoproteins that in response to the formation of antibodies given opportunity to qualify in some respect if there are clinical manifestations, because autoantibodies per se, they have an auxiliary role, but the key role is played by the clinical picture. So we see here the combination of lupus plus myositis plus scleroderma plus rheumatoid arthritis. So this is the variant of the overlap syndrome that is connected with the presence of relevant antibodies. As to anti-PM SCL implies myositis plus Raynaud syndrome plus arthritis. This combination is characteristics typical for this autoantibody. Anti-synthesized anti-Jo1 and other bodies. It is first of all polymyositis plus arthritis plus interstitial lung disorder, and anti-SSAB plus rheumatoid factor and antibodies to citrulline. So this set allows to suspect rheumatoid arthritis. For him, rheumatoid factor is typical, and Sjogren syndrome, which is very typical for this set. So anti-SCCA and B, these are very important markers that are always associated with the Sjogren syndrome. The list of main laboratory and diagnostic criteria that allow to suspect the overlap syndrome. First of all, this is general blood test and biochemical blood test, which allows to see creatinine, urine, total protein, blood electrolytes, liver transaminases, lipid spectra, and others. It also includes immunological. It's the biochemical blood test is very important when we speak about, especially to assess complement C3, C4 that are reduced in the backdrop of these diseases, and immunoglobulins G and M. As to the immunological markers, again, we say they are the basis for determining the anti-nuclear factor. Anti-nuclear factor, if it is positive, after this, we must test antibodies to anti-nuclear antigens that are presented here in order to decide which of them are present, and we are to connect them with the most frequent clinical manifestations of this or those diseases. Antiphospholipid antibodies, one more important component, first of all, to define the lupus anticoagulant, AT to cardiolipin, and antibodies to beta-2 glycoprotein. One more it is a very important component, especially for the lupus. Coagulogram, echocardiography, these are very important endoscopic tests. CT of the chest organs plus the complex study of the external breathing function, and it is necessary to define it. Rentgenography of joints, biopsy of the skin and muscular graft, ultrasound of abdominal organs, electromyography. Electromyography is not widely used, but I think if we have patients like this, if we have rheumatoid departments, we need to have an opportunity to make a video capillaroscopy of the nail bed to see the signs of the disease, because there are always capillary disorders in this case. Treatment depending on the organic lesion. First of all, we speak about arthritis. We know NSAIDs that are widely used, but we usually apply them only at the starting period. Then we use methotrexate, which is a golden standard for many immunological diseases, especially for rheumatoid arthritis. This is hydroxychloroquine, corticosteroids, and this is a component that is part of the complex therapy of these patients. For the active process, for the suppression of the active process, corticosteroids are very good, and it is good to start with them. And then we use basic drugs to reduce the share of corticosteroids. As to the rash, we use hydroxychloroquine here and the local treatment, including corticosteroids and tacrolimus, one more drug that is very often used for the lupus. Raynaud phenomenon. Here we use blockers of calcium channels, nifedipine, diltiazem. We use blockers of angiotensin 1 receptors and intravenous analogs of epoprostenol. As to when it is myositis, it is glucocorticosteroids, azathioprine, methotrexate, IV immunoglobulin, cyclophosphamide, rituximab. So we often prescribe this group of drugs to get the primary response or against the conducted therapy in order to reduce the activity of the inflammatory process. Rituximab has shown itself very well, although it is used quite widely in a number of diseases such as systemic lupus erythematosus, rheumatoid arthritis, and others. And speaking about the interstitial disease of the lungs, we use here glucocorticosteroids, azathioprine, cyclophosphamide, and again rituximab. It's only at the beginning of the therapy when we speak about the manifestations of pneumonia, and then when the disease progresses, we need to use the anti-sclerotic therapy. Cyclophosphamide is used. Thank you for your attention. And I would like to say that today this group of diseases is really difficult to diagnose because there are some common manifestations, autoimmunological manifestations and the clinical manifestations that are characterized by that may characterize autoimmune disease and has, for example, some symptoms of the second and the third disease of the group. This is really difficult, but the main thing is to define the presence of these combinations and to diagnose the disease as the mixed connective tissue disease and to find the good roadmap for the rheumatologist how to treat this patient. Thank you for your attention. Thank you, dear Vladimir Ivanovich. That was a brilliant lecture that was devoted to one of the most difficult issues of rheumatology. But so your presentation was quite accomplished, quite meaningful. Dear colleagues, now we will continue. We will have the next presentation. The presentation will be made by Professor Gaidukova from the Department of Rheumatology in the St. Petersburg University. She is Professor, Doctor of Medical Science, and she will speak about the diagnostics and treatment of IgA vasculitis, Schönlein-Hanoch disease today. Dear colleagues, dear co-chairman, I would like to welcome everyone at the Euro-Asian Congress of Therapists. Thank you for the opportunity to participate. And today we speak about diagnostic and treatment of IgA vasculitis today. We all know that vasculitis is a clinical pathological process characterized by the inflammation, necrosis of the vascular wall, leading to ischemic changes in the organs and tissues. The clinical manifestations are very numerous. It is a very interesting area, depending on what vessels and how they are affected, may influence the manifestations. And here we see classification of Chapel Hill 2012. So we see here vasculitis of large vessels, artery, Takayasu, and gigantic cell arteritis, vasculitis with the lesions of medium vessels. This is Kawasaki disease among children, vasculitis with the lesions of small vessels, granulomatosis, microscopic polyangiate eosinophil granulomatosis with polyangiitis, Schönlein-Hanoch purpura. So here you see the schematic image of this classification. On the right of the slide, you see classification, full classification. Here are all the vasculitis are divided depending on the size and type of vessels, and they're also divided into primary and secondary, or vasculitis, for example, of one organ, or there are vasculitis that coexist with other diseases, HIV-associated, hepatitis-associated vasculitis, and vasculitis are not only one of the most important clinical manifestations of the disease, but they're always associated with the unfavorable course and unfavorable outcome of patients. Today, we speak IgA vasculitis can be also primary and secondary. IgA vasculitis may be local, for example, of kidneys or neuropathy. But most frequently, IgA vasculitis is a systemic disease affecting many organs and tissues. Speaking about etiological factors, IgA vasculitis. If we speak about hemorrhagic vasculitis, we speak about gram-positive bacteria, viruses, parvovirus, cytomegalovirus, HIV, and also parasites, ascaridosis, strongyloidosis. I won't dwell on other vasculitis and would like to say that we speak about the etiology and the pathogenesis. So, according to the pathogenic classification, the IgA vasculitis belongs to those diseases that are associated with the immune complexes. And they always contain IgA. That's what makes it different from other vasculitises. So diagnostics of vasculitis is various, includes a lot of tests. Here we have blood test, biochemical blood test, acute phase indicators. We always look, have markers of the hepatitis B and C viruses. And if there are some organs are affected, then of course the biopsy of the organ is to be made, and the immune histochemical test is very important. We understand, because then we understand what is happening to the organ, and in this case it is easier to find the therapy. We know what power of influence can be applied and what will be the outcome. Speaking about systemic vasculitis, we may say that treatment of vasculitis is very active. We use glucocorticoids. The dosages are high, 0.5, 1 milligrams per kilogram a day. Speaking about the cytotoxic diseases, we use mycophenolate mofetil and cyclophosphamide in the dosages that you see on the slide. We use glucocorticoids, and this is and they are very effective. Yes, if you compare it with other diseases, we see that the cyclophosphamide is less effective than multicell the drugs. We use azathioprine, methotrexate. And if the disease is quickly progressing or very active, then we use pulse therapy with betiprednisolone. We choose the frequency depending on how effective our therapy is. Anti-B cell therapy, очень important for pulmonary vasculitis. We have a lot of evidence base about it, about rituximab, which affects very well as to nephropathy. I will speak separately. And if vasculitis touches upon the large vessels, such as aorta or kidneys, then we use organ-saving therapy, nephra-saving therapy, with the help of the APE. It is always part of the treatment. As to hemorrhagic vasculitis, IgA vasculitis is the vasculitis with immune deposits. It's characterized by the involvement of small vessels, capillars, venules, arterioles, and with the skin lesions and disorders, intestinal disorders, renal disorders, and joints. Mainly, our patients are children up to 16. If we have patients up 50, 60 hemorrhagic vasculitis, most frequently it is a secondary vasculitis against some other disease, mainly HIV infection or a tumor. And first of all, it is the skin lesions. We speak about petechias, palpated purpura, erythemas. So, orthostatism is very characteristic of this disease, and because it starts with the lower limbs and then goes up. And the purpura usually covers large areas of the body. That's why the patient is to stay in bed. As to the joint affection, so arthralgias are very frequent. Migrating arthritis is very frequent, usually of the lower limbs, so combined with the edema and myalgia. As to the GIT lesions, it is quite severe, and it is connected with some serious diseases such as dyspepsia, intestinal bleedings that can be fatal. That's why GIT lesions are treated very seriously. We always provide all the necessary tests, and it is a severe, usually, form of the disease, and we need to treat these patients actively. As to the renal disorders, it is also a very severe form of the vasculitis. And you can see it in 50% of our patients. Here we see isolated microhematuria in combination with proteinuria. In Japan, for example, they give the figure the 60% of the renal disorders in this kind of disease. And palpated purpura. So the age of our patients is less than 20, so they have pains in the abdomen that are intensifying after the food intake. It's very typical for the IgA vasculitis with the GIT disorders. Speaking about the secondary vasculitis, so we very often really see it. So here you see the 30% of all renal lesions are taken up by this disease. Amyloidosis, secondary amyloidosis is also a very frequent form of the lesion. IgA vasculitis with renal diseases is shown in this slide. You see the picture, which we usually see during the test. All these forms are independent from each other. It is very strange, but the activity of the disease itself is not proportional, is not connected with the absence and activity of IgA vasculitis of the skin and nephropathy. So it is a combined but independent states. It is very important. It is also important that speaking about pathogenesis, there are two mechanisms, independent cell mechanism and the B cell link is always activated, and the cells synthesize the increased amount of immunoglobulin A and circulating immune complexes, including these complexes. They affect skin or GIT, joints, or kidneys. It all depends on what pathogenic way the development or the disease developed. But there is a third type of the disease, is IgA neuropathy, that those patients that received tumor necrosis factor, TNF, says these cases were described for different drugs. And here you see the psoriasis patient. You see his data on the picture. You know, the drugs that are used for this treatment are new, and we need to know the IgA nephropathy is one of the adverse events that develop when we treat IgA vasculitis. Okay, here you see two clinical ways. First of all, it is benign. It's only hematuria that is developed, and here the function of the kidneys doesn't suffer, and this type of IgA vasculitis needs follow-up observation and some therapy using ACE inhibitors. But if we speak about the second form, the quickly progressing disease with the reduced function of the kidneys, it is dangerous because if you don't follow up the biochemical profile and don't compare the dynamics, you may miss the moment when the reduction of the renal function leads to the far-going form of chronic renal disease of 4 or 5 class. In order to assess the prognosis, it is necessary to use the NEST classification. It is the Oxford classification. Capillary proliferation, group E. This is classification fixes the presence of any sclerosis, irrespective of the volume and the degree of fibrosis of the layer. Up to 15%, it's 0, up to 30 is 1, and then it's 50 and more. Apart from the MCS classification, we see micropathy. If C1 stage is fixed, if over 25% or less are affected, this is not a good prognosis. And what is considered a bad prognosis? So you see that it is mainly the presence or the capillary proliferation, and it's a very good prognostic feature. It is considered also a bad prognostic factor. In here, in this picture, you see a comparative comparison of two bioptates that are assessed by the MS classification and the number of polospheres, and the authors believe that the first picture, the left picture, is a more favorable situation than the second picture. So biopsy is very important to prognose the course of vasculitis, especially on the earlier stages. If you suspect that the patient has nephropathy, you make a biopsy, make a biochemical test to understand whether nephropathy is present or not. If it is IgA nephropathy, so we assess it by the number of semi-moons and look at the prognosis of the patient and how actively the patient is to be treated. It is interesting that if ACA therapy is used and glucocorticoids is used in higher doses and with the nephropathic drugs is not effective. Well, what can we do? There have been described successful stories of treating this disease. Thank you, dear colleagues. The main idea I wanted to express that it is necessary to make a morphological and test to all patients of IgA vasculitis, because it gives us a clear idea of what type of vasculitis the patient has. And when we know the prognosis, when we understand the prognosis, we know how we are to treat this patient. Thank you for your attention. Thank you, Inna Zurabyevna, for a very interesting presentation, for a very practical presentation with good practical assessments. I would like to remind all the participants of our symposium that each of you can ask a question in the chat. We will send this question to our experts, and we will get a maximally competent and objective opinion about the subject you are interested in. So you are welcome to formulate your questions. And now I would like to give the floor to one more speaker, who is also representing the Department of Rheumatology in the Meshnikov Institute, Evgeny Alexandrovich Trofimov, candidate of medicine. And he will speak about fibromyalgia, formation of symptoms, and principles of treatment. You are welcome, Evgeny Alexandrovich. Dear colleagues, I'm very happy to welcome you. My presentation will be of a practical character, because that is how, that's what they were asked about by the organizers, and the choice of the subject, fibromyalgia, is not accidental. And for the last time, this problem hasn't received much attention in the recent congresses. We think it is not right, because we have a lot of patients with this pathology, and fibromyalgia is a group of diseases. And I would like to analyze the diagnostic criteria, their evolution, and to speak about the methods of treatment. We need to understand what we can prescribe, and we must understand that the team and multidisciplinary approach is very important and will bring success. Fibromyalgia is a state that is characterized by the syndrome of generalized pain, and it is a lengthy period of pain our patients suffer from. And the criteria for diagnostics are to be 3 months of this generalized pain. If we look at our practice, our patients, mainly female patients, suffer from generalized pain for many months or even for many years. And apart from generalized pain, there might be 4 other symptoms: fatigue, cognitive disorders, affective symptoms, all affective symptoms of anxiety, and various somatic symptoms that cannot be connected only with the pain syndrome. Probably it is some asthmatic component with the intestines, or probably with some skin rash with dermatitis. So these 4 syndromes are necessary complement to understanding what is fibromyalgia. What else is very important? What differs fibromyalgia from one more disease associated with such generalized pain? This is a very interesting formation of the pain syndrome, because all the researchers that deal in this issue say that there are national, ethnic, age, and gender features, and males and females have a different course of the disease. In the Russian Federation, there is a number of national features that I would like to present. These features have been published in a very good article of 2020 devoted to fibromyalgia. This is a fundamental research. And what is important, that these patients, female patients, they may come to any doctor, to doctor of any specialty, whether it is internal diseases, surgery, nephrology, family doctor. And on the average, in the Russian Federation, up to 5% of the population suffer from the fibromyalgia. But if it is a profile visit, then this amount can rise to 14%. 14% is quite a large figure, but it is very seldom diagnosed as a fibromyalgia. And despite the awareness of specialists about this, and the reason is that the doctors are not very well aware of this pathology. They don't know diagnostic criteria. It is not that the doctors lack knowledge. They apply this criteria, but do not apply them fully, do not apply them always. And also we follow the way of narrow specialization, and the specialists who would like to spend time and explaining things to patients are not frequent. And it's also explained by the limited time of the laboratory, of the outpatient visit, because the patient requires 15 or 17 minutes. She requires an hour or an hour and a half. So for the doctor to make a full examination and to provide a proper diagnosis, to find this causal link between the symptoms and the disease. The commonly known that this fibromyalgia is a female disease, but you know, for the last years, we have found such a ratio for 9 women to 1 man. But in my clinical practice, have I seen any single man of fibromyalgia? No, for 15 years of my work, I have seen only one man, only one male, and his fibromyalgia was of a secondary character. So it is a true statement that women suffer more frequently. They suffer more frequently in the menopausal period. A very important issue is to understand the triggers, to understand why fibromyalgia is developing, like a classical disease. It is difficult to understand because, you know, the reasons are very different, and it's difficult to highlight something basic, something main. So pain syndromes, infections, and the physical trauma, and the combination of the psychic tension and stress. Although this slide shows distress, but eustress is also very important. It can be the reason for the formation of fibromyalgia. I have a patient whose fibromyalgia developed after her daughter gave birth to a daughter. So she has a granddaughter. It is positive, but still it is a stress that violates her everyday life. Hormone violations, the use of some drugs, and also a very important issue, especially in the COVID pandemic, some vaccines. I put 3 question marks that vaccines can be predictors for the formation of fibromyalgia. But the classical notion of fibromyalgia as something without any triggers, so it has been changed because it is a neurodynamic violation of the body. And if there are there is a combination of different stresses that may lead to the development of the disease. So we know that the level of the serum serotonin is changing and is reducing, and the reduction of the main metabolite serotonin in liquor, 5-hydroxyindole acetate. Also, we also speak with HIPAA on nonsusceptive pain about peripheral sensitization. It is will always transform if you neuropathic pain. And so we see that it can form the concept, the evolution of the pain syndrome that is shown in this chain. Non-susceptive will transforms into the central sensitization, and that's how the classical syndromes characteristic for fibromyalgia are formed. So these mechanisms of central sensitization, are very important here, and we can explain why some female patients, some NSAIDs, like etoricoxib, have some analgesic ability. Some people say it cannot be so it is a placebo effect, because it cannot play any role in reducing this central sensitization. But you know, it is not true. The latest studies of 3-4 years say that some NSAIDs are not so much connected with the plasma proteins, albumin, and they 3 or 4% of ibuprofen can penetrate through the barrier and make such an effect. That's why NSAIDs do not only have a placebo effect. As to the diagnostic criteria of fibromyalgia, shows this ACR criteria, about checkpoints. And ideological approaches to fibromyalgia are changing. In 1990, you see these criteria that are still being that are applied. This is all we know. This is the detection of trigger points. And we diagnosed the case. In 2010, these criteria were reconsidered, and it concerned the fact that the patient should not have any other pain syndromes explained by some other disease. So the pain is to be connected only with the fibromyalgia. But in 2016, ACR presented modified criteria. So the differentiation between primary FM and FM syndrome as the manifestation of other diseases just disappeared. And that's why it's difficult to differentiate whether it is a separate disease or it is a complication of some other disease. We understand very well that everything that is presented in the slide, including trigger points, relate to the syndrome and to the FM per se. It is always a diagnosis of exclusion. There are no acute phase reactions, and a very frequent complaint is, I feel that everything is aching, my entire body is aching, and it may be paresthesias, it may be tingling, it may be itching, burning. It is always the increased fatigueness, it is the disturbance of sleep, it is cognitive disorders, and stiffness in the morning. These are so cognitive disorders are very important. Stiffness may last up to 8 hours. It is very important, and I return to the criteria that existed in the 1990s, that this pain is diffuse, it is generalized, and this pain lasts for at least 3 months. And researching the zones, we shouldn't forget about the checkpoints. It's in the buttocks, in the knee, and others. And if we find 11 out of 18 points, we have the diagnosis. And these disorders like rigidity, cognitive disorders, this is all that is to be taken into account. And recently, the ideology of the disease changed, and now we speak not about the points, we speak about the zones, the index of pain spread. So we need to we have several zones, 5 zones: upper zone, lower jaw, pectoral arch, then the upper right zone, the lower left zone, femur, buttock, then the lower right zone and the central zone, including neck, upper part of the spine, chest, of upper part and the lower part, chest and abdomen. So here we see the index of the symptoms expression, so, and the expression of each of the lower symptoms within the last week, each by the scale from 0 to 3, and the general result in the range of 0 to 9. When we ask patients to fix their symptoms, pain syndrome by the scale, They all know how to do it, but how it looks, how patients fill it up. I want to demonstrate from the own experience. This is my patient. To a simple request, please fix your pain sentiments and write it down every day. That's how it looks. Even if you have a look at it at first sight, you may see that the sum of suffering is very high, and the patients really experience very high syndromes. You look, they write all the details, how it aches, how it is connected with nature, with the weather. So they try to fight with their sleepiness, with their mood, independently. And very often patients take corticosteroids that have nothing to do here. Everything that is shown in the slide demonstrates a very capricious pain syndrome. So we have already spoken about the methods of FM treatment. But I think a lot is to be done here, because the treatment of such patients requires a team approach. It requires the consultation of the psychologist and probably psychiatrist. They have to explain why patients have such an affected syndrome. And here you see pharmacological and non-pharmacological treatments, and it includes physical exercise and cognitive behavioral therapy, multi-component therapy. Then the acupuncture is very effective, and the zones can be different, the needles can be different. Sometimes local anesthetics are introduced, and it really reduces the pain feeling. Probably it is connected with the placebo syndrome, yoga and other kinds of therapy that reduce the stress. As to the pharmacological support, it is well known. It is low doses of amitriptyline, local anesthetics. I think we are all using it, and it has an effect. As to the European recommendations about the treatment, we see that now everything is divided into 3 lines. The drugs of the first line is pregabalin, gabapentin, amitriptyline. Pregabalin is very important here. It gives a good reaction even with the small dose, say 25 milligrams before sleep. The second line includes the use of opioids, tramadol, up to 100 milligrams, duloxetine, and also those drugs with the capsaicin, in lidocaine, like plasters. Many patients like to cut it, to glue it, and so it gives a direct analgesic effect. And the third line, it is not very widespread in our country, although in Russia more and more attention is attached to this to synthetic cannabinoids. I would like to say that by my experience, by the experience of our department, the most effective and simple method is the prescription of pregabalin, because in all kinds of the disease, in case of any neuropathic pain, pregabalin has advantage of other analgesics, small opioids, opiates, and some antidepressants. And it's important to say it. I think about 45–50%, and it is very much for a discussed cohort of patients. They speak about the positive changes after even small doses of pregabalin. But what is very interesting and what is a taboo subject in our Russian agenda, although our Ukrainian colleagues, their president initiated the survey about the readiness of the population to use cannabis as pain killers. Because this level of trial where they discuss the use of cannabinoids during arthritis, during any chronic pain syndrome, especially in if opiates don't work, if pregabalin doesn't work, then the only way is to use inhalations of cannabinoids. And the research of cannabinoids as to the risk of death, they are not straight. And in Canada, for example, or even with the use of any means, the first, usually the use of cannabinoids. In conclusion, dear colleagues, I would like to say that specialists today underline the necessity of the complex multimodal approach to the therapy of fibromyalgia based on the principles of biopsychosocial approach. And of course, not only therapists, not only rheumatoid doctors, so there must be a team, including psychologists or even psychiatrists. And of course, the therapy is changing. Pharmacological and non-pharmacological methods are used more and more often. So I think it will give us more success in treating this very unusual and complex disease as a fibromyalgia. Thank you for your attention. Thank you. Dear Denis Alexandrovich, thank you for a very interesting presentation. Really, the entire symposium has a practical approach, and really you have shown very good practical methods, and the interest that this symposium has caused is proved by a large number of questions, and I would like to address these questions to our experts, and I would like to start with the question that is addressed to Vladimir Ivanovich. Dear Vladimir Ivanovich, thank you very much for your presentation. Could you please speak about the vaccination of patients with the MCTD? This question.
Вас не слышно. Наверное, надо включить звук. Так. Да, вот все отлично, отлично.
Владимир, все равно не слышно. Сейчас еще раз.
Сейчас слышно.
Так слышно? Да.
So, dear colleagues, as to the immunization and vaccination, especially now when we speak about COVID-19, we understand very well that any infection in the systemic connective tissue diseases can be fatal. That's why there are recommendations that we have developed with the Association of Rheumatologists of Russia, and these recommendations show that the anti-pneumococcus vaccination is to be made by all means, and there must be a vaccination against the flu. There is a 3-valence and 4-valence vaccine. There are different opinions about it. There is our local vaccine, foreign vaccine, 3-component, and the 4-component vaccine is coming. So it is necessary to be vaccinated because not only COVID, but complications, the severe complications, pneumococcus pneumonia, and everything connected with the flu, it is better to be vaccinated. So who should be cautious about it? Those patients who have a polyvalent allergic reaction to various drugs. If there were some reactions on the part of those vaccines that were already used in the prior periods, all the others must be vaccinated. One more detail. Of course, we are looking forward to the vaccination against COVID. And it should be done in the following way. Vaccination today, especially against the flu, is to be done by all means, because if some repeated issues arise, a month should pass before we may calm down about the formation of antibodies to the first vaccine. Last year, for example, we made vaccination against pneumococcus. In this case, there is one opportunity to define the type of antibodies. If it is high, there is no sense in vaccination. If there was no vaccination last year, then it would be expedient to do it, advisable, to be vaccinated. So I will cut the total number of questions up to 2, because their number is very big, really. The second question, please don't leave our translation and listen to the questions, because after the discussion, you will have a surprise, a pleasant surprise. Well, Vladimir Ivanovich, the second question, it was addressed to Inna Zurabyevna, but since she is not online, what is the role of hemodialysis in case of renal disorders in vasculitis? You know, this question has been discussed for many years. Everything depends on what vasculitis the patient has. If it is an associated vasculitis, it means that everything is connected with the somatic antibodies as a classical variants, is antibodies to proteinase in vasculitis. It is pyrrolixidase, which is more characteristic for microscopic polyangiitis. This granulomatosis, for example, with polyarthritis. These are the versions that are important. When we speak about the extracorporeal methods of treatment, with these versions, it is sensible to do it. Not only during hospitalization, but at a later date, plasmapheresis that is affected and probably with cytopheresis. I would like to focus on the fact that in Japan, they very frequently make these extracorporeal methods, and they are aimed at not only antibodies, but at improving the phagocytic activity and the elimination of the pathogens or antigens that are in the patient's body. That's why in our department, for many years, we have been conducting these measures to improve the therapy including systemic vasculitis. There are centers who are dealing with it, centers of the military academy, for example, and there is an opinion, especially in the foreign countries, where they recommend to conduct it in the limited variant, because they think that this is, first of all, a costly method, and it is not so effective in respect of treatment. This is a complex method, part of the complex method, and it is quite effective. Работаю, не могу, минутку. Thank you for your full answer. And one more question to Evgeny Alexandrovich. This question about qualfinizin, an alternative means, which is part of the syrup against cough. They say that this glafsivizin treats FM. Is it true? What is glafsivizin? This is a secretolytic and stimulator of the respiratory ways. I don't know. I can't say anything about it. It seems to me that pathogenetic effect is not provided, and it is either it treats the cough. But when using different specters of FM, there are very many placebo effects, very many placebo. There is no other disease where you can see so many placebo effects. That probably explains this question. I don't think that this is the drug of choice for patients with FM. Thank you very much, Evgeny Alexandrovich. A very short remark from me. With FM, we can't rely on the effect of traditional drugs and local therapy, but there is a certain experience in the United States, and there this disease covers about 20% of the population. Can you imagine what kind of problem they have in the Russian Federation? We are treating it not quite seriously, but in the United States, 25% of population have this disease, and it is diagnosed and it is treated. And Evgeny Alexandrovich was quite right in saying that along with the drugs that were enumerated, that we are using in the United States, they discussed cannabinoids in this case, but they also have the method of physiotherapeutic effect, stretching. And there are very many centers in the United States, and I visited them, and they use non-medicinal therapy. As to other not appropriated tests, not appropriated drugs, we should make a very good research work to prove the efficacy of this or that additional drug in treating fibromyalgia. Thank you very much, dear Vadim Ivanovich, dear Evgeny Alexandrovich. So our agenda is over today. You have listened to very practical presentations, to very practical reports that came from one of the most prominent medical institutions of our country, Vladimir Mazurov's center, and they raised very important issues that are discussed today. So here we can finish the work of our first day of our Congress. I hope very much that the work of the Congress, the beginning of the Congress, corresponded to your expectations. And the agenda that we have discussed today, fibromyalgia and the diabetes mellitus of type 2 and bone metabolism and its connection with the hydrocarbon metabolism. And this symposium that was very interesting. There was a symposium of geriatric aspects of managing diseases in elderly patients. And the last symposium that you have just heard was really very good. And I hope that many doctors, including therapists, would reconsider, will listen again. Yeah, we will rewind this symposium. And one of the advantages of our Congress is to see all the presentation in the archives. And if you haven't understood any of the slides, you may look at them again and become more informed about the problem. Tomorrow, we will have another day, and the cardiologists, lipidologists of St. Petersburg will present the up-to-date information. They will speak about venous thrombosis, that are very important theme today in the period of COVID-19 pandemic. And these aspects will be considered by our international team. And the following day, there will be also gastroenterological issues. So we will again discuss those questions that are related to comorbid pathologies and the interaction of different diseases between themselves. Dear colleagues, it seems to me that our Congress arouses a lot of interest of the audience who chose to participate. Very many people got connected, and I think that the Congress would be it would be excellent if it were not an online format. So we understand why it is online format. It is due to the pandemic that is spreading in the world, in our country. But still, we need to share our experience, our knowledge, to exchange this knowledge and our approaches with you through questions and answers, through the discussion that we are creating. Nevertheless, it is still online. Of course, it will never replace offline, physical relationship, physical communication. Nevertheless, that's what we have, and we need that the new coronavirus infection has seriously changed our life, our professional activities, and unfortunately, it is manifested in the fact that we have to reprofile our hospitals and very often leaving our narrow specialty. We help infectionists, we have reanimatologists, and this is correct because we have to help our patients. And the period of pandemic, many doctors have acquired new knowledge, new experience, and we decided that we need to mark the contribution of our colleagues, of those doctors that worked in spring and in summer and are still working today during the second wave of the pandemic in the red zone. And we decided to show you a clip that was recorded by the group of doctors, and it is devoted to the active work of doctors, nurses, volunteers in the red zone to save the lives of the patients. So now you will see a clip, and I say goodbye. I will see you tomorrow in the hall of St. Petersburg that will be conducted here. And our translation will start at 10 o'clock in the morning. Goodbye.
Труд в медицине, поверь, не мед. Славы в ней нету и нет банкнот. Только готовность помочь всегда. Нас вспоминают, когда беда, беда. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха, и нету воздуха, давят очки. И рот иссох, но ты же знаешь, зато тебе с небес улыбается Бог. Слились работа и сон в свой круг. Слились работа и сон в свой круг. Редко проводим с семьей досуг. Редко проводим с семьей досуг. Но тяжелеет больной. И вот тяжелеет, и вот долг наш врачебный опять зовет. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без воздуха, и нету воздуха, давят очки. И рот пересох, но мы же знаем с тобой, что нам с небес улыбается Бог. Со смертью идет война. В каждой победе своя цена. В наших сражениях всего трудней. Что мы теряем коллег, друзей. И снова кажется, что смерть куражится, выгнав опять кого-то из нас. Дом свой исполнив, он вдруг по наклонной что им там в небесах улыбается Бог. Мы точно знаем, что им там в небесах улыбается Бог.